Uh, Very good morning to everyone. I'm Dr. Surya Prakash, Chairman of Indian School of Urology. I welcome you all for this first live operative webcast of this year. This is a very interesting topic. We have chosen a topic of BPH. So we are going to show all the live surgeries of BPH, including right from TURP, the basic TURP, which everyone is supposed to know, to the latest missed procedures. All these procedures are being done from AINU Hyderabad. Dr. Mallikarjun sir, Dr. TUIP, and all the team of AINU is here to showcase all the procedures of the BPH. I welcome you all. I thank Mallikarjun sir and his team extremely, because they have taken a lot of pains to do this workshop on a Sunday. I'm in AINU, all the team of AINU is here to help us to give a uninterrupted good show of all the procedures. So for these procedures, today we have three more senior moderators with us. Dr. N.P. Gupta sir is the senior urologist. He's the past president of USI from New Delhi Medanta. And we also have Dr. Deepak Kirpekar sir, who is also the past president of USI from Mumbai. And we have Dr. Anil Vashne sir, who is the chairman of the USI Benevolent Fund. All these three moderators have witnessed the prostate surgery, right from open surgery, where we used to have a lot of morbidity, to the newest procedures which are being done as a daycare procedures. So they can throw a lot of light and help us to go through these surgeries. Now, before I start, I welcome the office bearers of USI, the president, Dr. Keshavamurthy sir, Dr. Vittamite sir, who are here with us. I request Dr. Keshavamurthy sir to give his opening remarks. Over to you, sir.
Thank you, Dr. Surya Prakash, and welcome all of them who have joined in for this live operative webcast, which is being done from the Asian Institute of Nephrology and Urology, team led by Dr. Mallikarjun, Dr. Taif, and Dr. Syed Ghaus. They have been doing it regularly. We had done it in the past, and that's why we chose AINU, because they are updated in the technology and it's very easy to do. And I must thank Mallikarjun and team for getting all his staff on a Sunday to help us do this live operative webcast. Thank you, Dr. Mallikarjun. And I hope all the delegates will have a feast of all the procedures which are being planned today. And they have planned 7 procedures, which will show all the procedures which are being done for the benign prostatic hyperplasia. And I must also thank Dr. N.P. Gupta, the past president of USI, Dr. Deepak Kirpekar, the past president of USI, and Dr. Anil Vashne, who is the past president of the North Zone and the president of the Benevolent Fund, who is also a master in HOLEPs, who is there to moderate these sessions, and they will be interacting with the operating surgeons, and delegates who want to ask questions can go to the chat box and put their questions, and those will be conveyed to the moderators and to the operating surgeons. So I think it will be a useful webcast, and all the best to Mallikarjun and his team. Over to you, Dr. Surya.
Thank you, sir. Thank you very much. Now I request Dr. Vittamite sir to give his address.
Good morning, everybody. Dr. Keshavamurthy, President of Urological Society of India. Of course, Dr. Surya Prakash, the chairman of the Indian School of Urology, and 3 well-known figures in the field of BPH who are moderating this session in this morning. Past President Professor Narmada Gupta, Dr. Deepak Kirpekar, and Dr. Anil Vashne. And of course, I would like to thank the operating team in INU for doing this service on Sunday, and all the members who have joined, and those who have not been able to join, we can watch it later on also in the e-learning platform. And as we used to tell that TURP is the bread and butter of the urologist, I say now TURP is not the bread and butter, it's only the bread. Now butter is somewhere else also, and that is the minimally invasive procedures are there. So mist has come in a big way. So let us see from these experts whether which one is the bread and what are the butters in this prostate surgery. And I'm sure everybody will enjoy this. Thank you very much, Dr. Surya and our President, Dr. Keshavamurthy.
Thank you, sir, for those words. So we have with us here Dr. Ghaus, Senior Consultant Urologist from AINU. So Dr. Ghaus will brief us about the cases which we are going to do today. Over to you, Ghaus.
Good morning, everybody. A very warm welcome from AINU to all the delegates who are watching it live and who will probably watch again and again on the e-learning platform as well as on the YouTube platform in the future. So today we have got a nice lineup of cases, starting from a smallest gland of 15 cc to a very large gland of 100 cc, with a wide spectrum of different procedures, starting from bipolar TURP, iTIND, regular TUIP, Rezum, HOLEP, as well as a UROLIFT. So all the spectrum of surgeries, we are planned to have it today. To start with, Dr. Mallikarjun sir is going to start with a simple regular bipolar for a medium-sized gland. If time permits, at the end of the procedure, we'll have a very interesting talk on continence or incontinence post transurethral surgeries by Dr. Malik sir. And if all are ready with the due permission, can you start the procedure, sir? Keshav sir.
Thank you, guys.
Yeah, you can go ahead with the procedures.
Yeah. Yes, sir. So
We'll have a presentation of the case.
And you
Please go
can,
ahead.
Surya, you can ask the moderators to take over now.
Hello, can you hear me?
Yes,
Good
we can hear
morning.
you.
Good morning, everyone. Sorry to be late. I was having little trouble with Zoom. Anyway, I'm connected now. I'm not seeing my image yet.
Camera.
My video is off. Okay. Good morning, Malik.
Very good morning, Dr. Malik.
Good morning, Mr. Sir.
Good morning. Good morning.
It's my honor to operate a TUR in front of two legends of TUR in India. I'm happy to say that today. Thank you very much for being invited to say this session, and thank you, India, sir, for giving us this opportunity. I think the whole program is oriented towards learners of TURP and the experts in TURP. So bear with me if I'm going back into the very small basics, which probably might be a little bare into majority of the seniors. The second point which I wanted to say was, Uttam's dialogue was very nice to say that bed and bottom TUR is only the bed and the better is between missed procedures, but one thing we cannot.
Mallikarjun, check your voice. Your voice is not clear to us. Please ask the cameraman to correct.
Yes. Are you able to hear me, sir?
That's
Yeah,
better.
it's better. Yeah.
Better now.
Are you able to hear me? So, Uttam was talking about bread and butter. Bread is a TR and the butter is going to be the mixed procedures. But you can't do anything with having only butter, so I need to
Malik, still it is not good. The sound is not good.
Can you increase the voice from my mic, please? Are you able to hear me, sir?
There's a echoing, there's probably your voice is clashing with something else.
1 minute.
Voice not clear.
1 minute, sir. Just 1 minute. How is it now, sir?
Yeah, better. You can start again. Yeah.
Yeah. So I was talking about Uttam talking about bread and butter. I said TR is the bread and the butter is going to be mixed procedures. But we need to have the bread, otherwise we cannot enjoy butter too. So I think having understanding the TRP, the basics of TRP is essential.
No, your voice is again not coming properly. Audio visual, please check.
When you start speaking, it's okay, and then gradually it fades away.
Are you able to hear me, sir?
This is better.
Yeah.
But I think I just get my hand also. I was talking about getting better, but I think TUIP is a good and the better is going to be the missed. So one TR is very essential for any urologist. So well, we are going to the basics of TR. First, I think I will show the equipment. It's a very basic equipment what is necessary. If you see the trolley here, what you require is dialysis to calibrate the difference necessary.
Voice is breaking again, Mallikarjun. Probably you are using two mics. Keep your mic, one mic away.
How is it now, sir?
No, you start well, and after some time it goes down.
No, can you let them? What was it? Yesterday it was quite absolutely normal.
Now it's perfect. Whatever
Is it okay now? We had a trial yesterday, everything was all right.
Yeah, we can see the equipment trolley.
Is it okay? Is it okay?
Yeah, it's okay now.
Yes, okay.
The equipment trolley I was talking about is the straight hospital and the scissors.
Again, it has gone down. Malik?
Yes, sir. Hello?
Yeah. Now go ahead.
Okay. So, the cystoscope sheet, either you have a 30 or a 0, most of the time we shift it to 30 degree scope, a cystoscope, a visual actuator, a 24/7.
Again, voice fades away. We can't hear you.
Deepak sir,
Yes, it.
are you able to get it now?
Yes. Now we can hear you.
Start and see.
Huh?
Malik, we can hear you, but when you continue speaking, it fades away.
Oh. I think they are connected. Yeah, idiotic. Huh?
నథింగ్ మోర్ దెన్ మేడం ల్యాప్టాప్ పెట్టేసి దాని నుంచి హెడ్ ఫోన్స్ మాట్లాడుకుంటాను.
Malik, start talking. Let's see.
No, just getting another headset for myself.
But now sound is good.
My sound is good. Are you able to get a vision?
I've got the trolley in vision.
No, you got the trolley in vision, right? That's okay. So I was looking at the instrumentation part, which I said about the cystoscope, a receptoscope sheet, which everybody know, and bladder incision, right? So we are going to do a standard TUIP for this patient, and the saline, the betadine, the jelly, and actuator. These are the 3 leaks, but it's a different modified version of it. And the 3-way catheter. So this is the trolley. I kept the urinary catheter here also to show what is the necessity of the urinary catheter here is not to use a urinary catheter, but I just wanted to show the display of the patient also here. If you put a position here, the 2 things which are necessary for a position is going to be...
Again, the voice has faded away. Malik, voice has faded away.
Why don't you show the operation, don't talk.
I'll just pass the result while I'll talk the moment to the city.
You don't keep Malik Otis urethrotom on the trolley?
No, I don't have an otis urethrotom because we don't routinely practice otis urethrotomy at all. This patient was on a catheter, so I'm instilling jelly into the urethra before I start off. I instill the jelly adequately into the and then
We can't hear you. We can't hear you.
What is doing?
I'm 1 minute. It's presentation. ఇది పెట్టుకోవచ్చు కదరా సార్ వచ్చు కదా.
Good morning. So I'll do the case presentation for the first case. It's a 64-year-old gentleman with diabetes, hypertension, and coronary artery disease. He has stopped antiplatelets. He had long-standing obstructive LUTs and a recent episode of acute urinary retention. After failing trial void, he has been planned for TURP. On ultrasound, it is suggestive of a prostate of volume 30 cc. Clinically, it's a grade 1 prostate. So plan is TURP. Thank
So
you.
your voice is clear. Can you do the commentary while Malik is operating?
Yeah, I'll do that. No, are you able to get the voice now?
Yeah, better.
Okay. I was about to show, sorry for the inconvenience, I was about to show the importance of the positioning.
We've lost the image.
So,
Now we've got the image, right?
I got it, okay. So the only 2 things which I wanted to show in the position is most of the time is underrated is the position of the leg. One of the most common problems where the patients complain is numbness in the lateral cutaneous layer of the thigh, on the lateral aspect of the thigh. That is basically because of the stretch of the lateral cutaneous nerve under the inguinal ligament for a badly positioned lithotomy. So lazy lithotomy, that is called
Sorry, Mallikarjun, sir, sorry, we cannot hear you at all. Your voice is breaking. I don't know. Something is wrong with audio-visual system. You have to call that person and get it rectified. Or you don't speak, somebody else can speak on your behalf.
Inconvenience for a moment, few minutes. I think it will be set in the next 2 minutes. So I was talking about the importance of the position of a lazy lithotomy because to avoid a lateral cutaneous nerve at the high neurotaxia which can happen in many of the we complain about numbness in the lateral aspect of the thigh in the first few months after the TURP. So this is what we need to understand, that we should not be putting the actual lithotomy position, that so that we can avoid that sort of a injury to the lateral cutaneous nerve of the thigh. The second thing is the height of the irrigation. Height of the irrigation is so the height of the irrigation is always appeared to be around 60 centimeters, especially in a monopolar TURP. That is what I want to show in a with the urinary catheter here, but the more the height, the higher the chance of more fluid going into the intravascular spaces. That's the reason why the height has to be around 50 to 60 centimeters, not more than that. In a bipolar TUR, it may not make much of a difference because we are using saline, but in a monopolar TUR, it makes a difference. Regarding the mucus calibration, the mucus is quite adequate. So I'm going to pass the cystoscope to the.
But Malik, audio quality issues are still there. We are getting messages from all the participants that they are not able to clearly.
I'll correct it in the next 2 minutes, sir, because I'm just opening a Bluetooth way of doing it. There is something which is happening here.
So what I would suggest is you don't do the talking. Let somebody else talk. You can take the mic off.
Okay. Receptoscope, visual actuator. The second thing is keeping how are you keeping these cables onto the TUR? The first thing is going to be the tubing which gets the saline, because this is not going to be moved at all. It is going to be attached to the outer sheath, so that's the first one to go. The second one is going to be the light cable. This is the heaviest one. Most of the time there is a lot of crumbling of the wires which has to be prevented. There is a light cable that has to go on to the next level, because that stays there and we will not be needing to do. Majority of the times I see people having a loop of the thing here like this, which will hamper their hand movements. That's the reason why we need to keep it there. And the rest of the two things, whether it is the camera or the this diathermy cable, they are going to be attached to the instrumentation, so they are going to be coming out and in most of the time. So let them be on the right side of your side rather than the left side, because otherwise they will be from the right hand, so I'm keeping them on the right side. So this is the basic ergonomics of TURP, what can be adapted to when you want to do. So I'm taking a visual obturator, which is going to be used for passing the scope into the jelly, please. Right. Okay. Jelly. Selenium.
This is a small prostate, Malik. Say something about jelly. People have lifted the mucosa by simply pushing the jelly. So what is your take on that?
It's a, which one? I didn't get your question, I'm sorry.
No, the question is that if you push the jelly hard, you can lift the urethral mucosa and spoil the procedure. As well as later on, you can have strictures. So we would like to have your tips on introduction of jelly before
passing the jelly. I'll give you a tip when I'm passing the catheter. So let me have the understanding that when I'm passing the receptoscope with a visual obturator, I'm able to see a normal bulb, and I'm able to see the and I see a very small grade 1 prostate only.
Void fades away. You start well and then it disappears.
Yeah, I'll be setting it, sir.
We can see the endoscopic view. We can see the small prostate and some flakes inside the bladder.
Are you able to hear me now better?
Yeah. It's interrupted.
Not yet. 1 minute. 1 minute. Okay. They were just connecting.
Got it? How is it now, sir?
Now it is better.
Yeah. Okay. I think I fixed it.
Yeah.
Okay.
Now it is all right.
Good, sir. Thank you. Thank you so much. So what I was saying was about the display of the cables here on the patient. One is the fluid cable, which comes the first, and then is going to be the cable of the light cord, which is going to be the heavier the next, and the right side is going to be my camera cable, and the diathermy cable. Because I'm a right-hander, I'll be moving my right hand on this side direction. So that is the thing what I was always talking about. This being
Malik,
a very small prostate. Yes, sir.
Do you normally do a cystoscopy before you put a resectoscope with a visual obturator?
Yes, but this patient, usually that is necessary, but this patient had a catheter already, so I thought I can pass a visual obturator with a resectoscope. That's the reason why I put. But it's a mandatory to put a cystoscopy sheath first, have an inspection of the bladder completely, and then proceed with a resectoscope, because we can't assess the urethra. Sometimes even having a catheter, the urethra might be bad.
Yeah. Another question.
So,
there is no stricture per se, but if you find the urethra is tight,
yes.
how do you go about it?
There are two ways to manage. Number one is going to be put a dilator, which I've shown, or other thing is going to be passing a Otis urothrotom and giving a deep cut. But most of the time, having patients having a catheter, there should not be any problem in passing a resectoscope of a 24 size.
Agreed.
That is what. And the third point which I wanted to show is ergonomics during your TURP. Again, the height of the chair should be in such a fashion that your knee should be a little obtuse, so that you can move your foot very easily. If you have a knee which is acutely bent, your knee with your foot cannot move. That is the reason for problems. So you need to have a height of the chair in such a fashion, the angle at the knee is going to be little obtuse, so that the movement of the foot is going to be easy. And number two, when you put the resectoscope inside, if you suppose the resectoscope is in this position, I expect the head and down to be down, so that the resectoscope has to achieve a position of this nature, so that it is much more ergonomical to work with. So the head end of the patient is depressed, so that the resectoscope is pushed in the urethra in an absolute horizontal position, so that it is more ergonomical. Otherwise, you working out this fashion is not going to be easy. That's the reason why you need to push it in this direction. Comment, sir.
So what is the size of your resectoscope?
24 size, 24 French.
What is the uroflow of this patient?
He is on retention.
He was in retention.
He's on a catheter. So I am using a bipolar energy. So the question now is, what are we trying to do? What is this with very small prostates, non-diabetic patient, he's got a mild retrobucculated bladder. There is a very, very likely chance that there may be a hypotonia of the bladder also. There is a possibility. Well, that is not a point of discussion now. The point of discussion is only the technical part of it. Suppose I need to do a TUR in this sort of a gland. I have two options. I give a incision on this side or an incision on this side and resect the area because of a fear of a bladder neck contraction that can happen. Or to do away with it, you need to make a small strip of the mucosa, what is being seen in between the loop above, and leave that amount of area not resected at all. So that is the two ways of doing it. I have my own way of leaving that strip above so that I can prevent bladder neck contraction. But I don't think that makes a bladder neck contraction zero incidence, but it still have a chance of a bladder neck contraction. The third thing is going to be identifying the structures. We always say whatever moves like this is the external sphincter, or this is the sphincter what we are talking about. I would say the sphincter extends right from the lysosphincter, smooth muscle sphincter, go from this direction till the pelvic. This is the pelvic diaphragmal movement. That's all, till this area. So the length of that lysosphincter, what is left behind up to this point, is the functional urethral length. That is what is the reason for continence in the postoperative. Why we keep a verumontanum as a mark? Because this length will become 1.2, in which case it will be the continence is going to be preserved. Any cut beyond this area to this area is going to decrease the length of that functional urethral length, and incontinence is going to be likely. So everybody says this is the external sphincter. No, this is the lowest portion of the pelvic diaphragm, up to which the concentration of the smooth muscle sphincter is going to be the highest.
Mallikarjun, why not do a TUIP only? Why you have to do the resection?
I understand, sir. That's always absolutely the two reasons why I look at being done. I want to decrease outlet resistance to the maximum in this patient, especially with a small prostate and a retention recently happening. Though non-diabetic, I'm not looking at a hypotonic bladder per se, but still it can be a possibility, in which case I resect as much as possible so that the outlet resistance can be decreased. A simple TUIP is a good option for a young fellow with a normal bladder and a good contraction of the bladder. He'll be able to. But here I want to decrease the outlet resistance. How much is going to be decreased? Depending upon the amount of volume of the alpha blocker activity here, which can adrenergic activity can be decreased. That's the reason why I'm trying to prefer for a TURP. And second thing, I just wanted to understand for the youngsters, how do you do a TUR? I think the easier one to do is a bigger gland. The smaller glands are much more difficult because you tend to go into a problem much faster. So I start off most of these in these areas as a 6. There is no specific way of doing it. I would say I start off at a 6 o'clock. There is something in the tip as a 6 o'clock. Understand how much is
what I do a modified TUIP. So I make 2 incisions at 5 and 7, and
Perfectly,
the median lobe only I resect. Then I leave the lateral because there are hardly any lateral.
Yes, sir. That's what most of the time even I practice also, depending upon the scenario. Absolutely, sir. I do agree on this. So what I'm trying to do is I'm just showing a small sort of a resection where how we go about. The only thing is, majority of the times people have a tendency that they look at this trigone and try to make this as a straight line from here till the trigone. That's a mistake. I don't think you require to excise too much of circular muscle fibers. In fact, that produces higher incidence of bladder neck contracture. Making it open like that is not going to be the answer. But at present moment, according to your this thing, sir, I always say I leave this amount of the tissue above so that there is a mucosal entity. Even if there is a bladder neck contracture, the patient's chance of going into retention is less likely. You still have, you can correct it at a later point of time. I don't say that leaving that mucosal strip is going to prevent a bladder neck contracture, but what is going to happen is going to be that the patient is unlikely going to retention because that amount of mucosa is going to be there.
Malikarjun, I would like to reinforce on this particular point what you have mentioned, that mucosa should be left at the bladder neck. That is my practice. So your picture, the bladder neck contracture incidence goes significantly down.
Yeah, sir, but the thing is, the bladder neck contraction, even if it happens, the patient doesn't go into retention, sir, because there is a mucosa. See, this amount of mucosa is the only thing which I want to leave. This strip I want to leave. They don't go into retention. So how do you, in fact, for the beginners, I would say, how do you think about resecting in a smaller gland? Take a cut. You'll create a ridge here. Take out this ridge. Smaller glands are more dangerous. Instead, the second point is take a half a loop and cut so that you know at what depth the loop is moving. So that is called half loop cut. That gives you a better idea how much you're going to cut. See this? The whole loop is not inside. Only half the loop is there inside your tissue, so that you know at what depth the loop is moving. So that is the way you go about from above. Actually, in fact, this is the original Nesbitt's description where he says go from bottom towards up and again from up towards the bottom till you reach the capsule. So the advantage of it is even if you have a problem at any point, you would have resected majority of the tissue on either sides, so you can stop the procedure and come out. That's what has been initially driven by Nesbitt, which he later modified with resecting a groove at 11 o'clock and coming down along the capsule so that devascularization of the prostate can happen. So you start it, you see that a small amount of tissue, I already separated the area between the bladder. This is the bladder, the circular fibers, and that's a prostate. This is a prostato-membranous junction. It is very easy. Whenever you go and flatten this bridge, what will happen? You disconnect this bladder to the prostatic. This is a prostato vesical junction. So that should not be open. Any excision in this area can lead to bladder neck contracture and a fibrosis in the postoperative period. So this is what we need to understand. Your comments are on that.
You are absolutely correct. It's the extravasation that happens in that area which is responsible for bladder neck contraction.
Yes,
absolutely correct.
So again, I'm saying I'm coming from top to the bottom.
You are seeing so many, this prostatic calculi are there. So
yes,
the
I've reached the capsule.
And this calculi, I think so they are the main culprit for the obstruction in the flow.
I've reached the calculi, but anyway, the presence of a calculi and the visibility of the calculi suggests that you have reached the capsular area, because these calculi are always there between the adenoma and the capsule. They are compressed corpora amalacia which form into calculi as a calculi. So prostatic calculi are a gap, is a plane differentiator between the adenoma and the capsule. And the capsule. So if you remember, if you see that now, I'll let me show you. So I have achieved what I have to take it out. I have taken out adequate amount of tissue in the prostatic fossa and decreasing the outlet resistance to the maximum. I reached the circular fibers of the bladder, which is there. These are circular fibers of the bladder which are seen. And number two, I've almost gone up to the capsule. In fact, I was trying to take out the prostatic junction, opening the vesicoprostatic junction. Whenever you have it, be careful. You have reached it here. You cannot go beyond this. So you should know how much you can cut. So you always cut with a half loop so that you know at what depth the loop is moving. So the same thing I'm doing, half loop and then half loop here. So you know how much depth it is moving. So I'm trying to take out as much tissue as possible. I don't need to take out more. The idea is not to take out more. Take out what is needed, not to take out more. So that's what. As a urologist and a trained surgeon, you tend up to have more tissue to be taken out because that satisfies our ego, but we need to restrain that sort of a thing. So I think my resection is complete. This is the verumontanum. I leave this amount of tissue, doesn't matter. And this is the edge of the tissue. If you look at my end of the resection here and the end of resection here will not match. In fact, this will be towards the B, and that in the roof it is going to be towards the bladder neck. That's the reason why, because the sphincter is going to be a little. It is little. What do you say? It is towards the bladder neck in the roof. That's the reason why your resection should be limited and it should be shorter here rather than here. One of the advantages of leaving this strip is going to be that you're not going to be very close to the sphincter because there's hardly any tissue here. And if you even one or two cuts may lead to a sphincteric damage.
What about apical tissue? You like to resect or you want to leave it?
This is the third thing I'm going to come back, sir, now. So what I've done, I've debulked the tissue inside the prostatic fossa. I kept all our anatomical landmarks intact. The bladder circular fibers are opened. The hemostasis is almost always secured. And now I look at this area where the mucosa is there. Majority of the times, post-operative bleeding, if somebody comes for a clot retention, the most common areas of bleeding is going to be the vesical varices under the mucosa in this area. And the second thing is a roof. Most of the time, the beak of the resectoscope will be pressing that bleeder if you are looking in a end-on view. So it's the roof from where the bleeders will be there. And this cut edge of the prostate tissue is the area where you get the bleeding. So I started looking into that area. I've just finished it. I think we need to avoid this sort of a road rolling effect onto the tissue. You have a beautiful energies now. You need to have a point coagulation. The higher the amount of coagulation you have done in the fossa, higher the chance of having a secondary bleeding happening because this tissue necroses and comes out. Your comment on that, sir? My feeling is the apical tissue is not much here. Probably the next case will have more. Possible I take out a little here. I don't think I have any apical tissue left here. I think that is what I am looking at. See this? This is apical, this is a mucosa. Nothing is there. Possibly a little here and nothing later. So I have done my resection and I think everything is over.
Malik,
Yes, sir.
please show us the fossa with the empty bladder, please.
Yes, sir. Definitely I'll do that, sir. That's what I need to show. It's always in a distended bladder. It looks very good. So what I do is I'll show the empty fossa after it. I'm just evacuating the fragments. Why I'm saying is every helix evacuator, for beginners to understand, every time we do this maneuver in the bladder, there is a high chance of small bleeders opening up. So whenever you do this job, you feel or completely emptied the bladder, you have finished the job, just don't get away. Put your scope inside and see whether it opened any bleeders or anything like that. So this is one point most of the time people miss. Second point I'm talking about, never do completely empty bladder. You suck your trigone into the sheath, that causes more post-operative irritation. So fill the bladder to certain extent. Half, that means around 100 ml of the bladder saline should be there, and then stop it and start doing this. And number two, don't push it like this and start doing evacuation. Just make it a little upwards so that it doesn't touch or suck the trigone. That's the reason why you positioning of this sheath also during your helix evacuation is very important. Your comment on that, sir?
No, I agree with you what you are saying. And only when you decompress the bladder, there is a pressure goes down, and that may be also a reason for the bleeders may come up.
Yes, sir. That's exactly what happened. And that's the reason why I'm looking into the first areas I look at is the bladder mucosa and then the 11 o'clock and 1 o'clock position where the bigger bleeders are there, which I look at for a bleeding there. So before the bladder over distance and the prostatic fossa over distance, finish these areas near the bladder neck, prostatovesical junction, and 11 o'clock and 1 o'clock, where the bleeders are going to be highest, or probably the troublesome bleeders are going to be there. And then the bleeders inside the prostatic fossa or towards the sphincteric area are not real problematic bleeders. Once the bladder fossa empties or fossa collapses, you'll see multiple ridges again coming. Don't be in a hurry to resect them. Once you resect them, you may open up the capsule. See, this is a half-filled bladder, sir. I've just emptied, and this is a half-filled. Stop the saline also, or I open the saline very little. You can see how it looks like.
Right.
Deepak sir. And second thing, people have a tendency to buzz this. See that? Why not buzz it? It's bleeding. It's bleeding. Please don't do that. These bleeders are not going to
Cause
any problem. Just leave them like that. The bleeders around the sphincteric area are better left alone so that they're not going to be coagulated. You are unnecessarily damaging the muscle. These small bleeders will never cause. There may be one or two at this area, just at the before the ejaculated duct muscle, but possibly they can be taken off very easily. But not in the rim, not on the edge of this area, not in this edge. I've done my resection. I opened up, and everywhere it is already into the capsular area. Half-filled bladder shows the prostatic fossa is completely open and empty. And at one place, I opened up this area also. It's an over-distended bladder. It comes in, and I'm looking at a bladder. I don't see anything, just empty. And see, I don't see the irrigant is quite clear outside. So the second point is, okay, I'm seeing into the bladder for any leftover pieces. I don't see any pieces inside. And now I take out the resectoscope with filling the bladder to a certain extent, and then taking out the resectoscope is better. Why? Two reasons. Number one, by the end of this resection, you may have small clots lying down in this area. Very small clots may be there. You will not be able to take it out. So when you have a little full bladder, what you can do with the bladder, with a full bladder, you just, take it out. Any clots are going to be taken care of from this flow of the urine itself. That is what the idea of filling the bladder. Many people.
How is the flow now?
Flow is good, sir. See, many people tend to press it and see whether the flow is good. But in fact, the idea is not to see whether the flow is good. The idea is to take out that small clots in the prostatic fossa, which can be retained at the end of the resection. So there was a discussion about how to pass a catheter. Can you switch off this light? Switch off the light. So Anil sir was asking, not this light, Hey, on. Anil sir was asking how to pass. We have a very difficult, I don't know whether the newer urologists ever know how to hold, the younger pipes are being taught how to hold the penis at all when we need to pass a catheter. Number one, we need to hold the penis with these two fingers, retract the thing, and then if you have a syringe or a jelly, let it be vertical, because it should go into the line of the urethra. Let it be vertical. Push this completely towards the tip, and then you are compressing from the lateral aspect, and the whole jelly will go inside the urethra without any problem. That's how. So that is how I see many a time people pushing the jelly like this or jelly like this. No, it should be in the line of the urethra. The second thing about the catheter, every catheter has got a cover. People take out this cover and hold the catheter with the hand. That's not meant for it. It is meant for a no-touch technique of passing a catheter. You have a catheter, you have holes here. Don't pass holes in the top. Take this roof, which is there smoothly, it goes to the roof, and hold the penis, and then pass the catheter inside. When you are passing, slowly withdraw the sheath above. So this is the actual way of a no-touch technique of passing a catheter into the bladder. People will take out this and hold the catheter and pass it. This is a no-touch technique. So I think these are the basic fundamentals of catheter care, or possibly insertion of a catheter into the bladder. Your comments, sir?
How much do you inflate into the balloon?
This is a very small prostate, so I may use only 20 ml or maximum 30 ml. I don't think any time, you see, I am against too much of a traction. I don't use much of a traction majority of the time, so I just use probably 30 ml is the maximum.
Okay. And you said you don't use much of a traction. That means you do use a traction.
Very occasionally, sir. Very occasionally. For this sort of a gland, I don't use a traction at all.
Mallikarjun, your comment about whether you like to leave the balloon in the prostatic fossa or in the bladder?
No, sir, in the bladder.
In the bladder.
See, I feel that, thinking that the balloon or a traction is a way to control the bleeding, is not the correct way. You need to control the bleeding on the table and finish it, then only you can think.
No, I think Malik,
Sir,
traction has a role if you have accidentally opened the sinus.
exactly.
Then
Sir.
traction helps to control the sinus bleeding because you cannot control it using your diathermy.
Exactly, sir.
That's the
Sir,
only
there is
place
two
where
ways of
traction
looking
is
at it.
necessary.
Perfectly, sir. There are two ways of looking at it. Capsule is open. Whether the capsule is open under which there is a vein which is open or not. If you open the capsule, you decrease the irrigation and see, or close the irrigation and see whether there is any venous bleed coming through it. If there is no venous bleed, I don't think it is going to bleed. If there is a vein which is open, you probably decrease the procedure time as much as possible, and that is a case wherein a little amount of traction will
Absolutely correct.
vein and stop
So,
it.
Mallikarjun,
Sir.
the idea of putting the traction, I'm not saying very vigorous traction, but mild traction, penile traction, what we call it.
Sir.
That is, Dr. Wadhwa has taught me that. And the advantage is that even if there is any oozing in the prostatic fossa, the blood will stay there and it will form a clot and bleeding will stop. Instead
Perfectly,
of
sir.
the blood is going into the bladder and giving the red color to the urine all the time. So that
Perfectly
is
said, sir.
one of the advantage of putting a mild traction, penile traction, what we call it. And anybody who has worked with me, they must have seen me putting in all my cases.
Sir,
Second
perfectly
thing is,
said, sir.
while we are shifting the patient or he's in the spinal, once my anesthetist, Dr. Gode, he told me ki when they were extubating the patient from general anesthesia, he coughed or something and bleeding started, So he said ki,
Exactly,
that
sir.
is the reason why you should have a mild traction. There's no harm in that. You can sleep nicely. Night you don't
Absolutely,
have to
sir.
come
So
back.
the 2 points. That's true, absolutely true, sir. In fact, even we used to do the same thing, sir. But two reasons why: if your resection is quite good, like we have not opened the capsule, possibly you have done a great coagulation. This is a very small gland. There is hardly any bleeding. In which case, traction is avoidable.
Yes.
The reason why is for the beginner's purpose. I am telling you again. At the time of your coagulation, look at your monitor whether pressure is normal to the pre-op level or not. Majority of the times in this sort of a small glands, we end up in doing a coagulation when the pressures are 70 and the patient is shifted outside. Yes. And the pressure becomes 150 and starts bleeding. That's one point. And second point, try to understand any traction, the more the traction, higher the chance of bulbomembranous and the penoscrotal junction strictures. There are 4 levels of stricture. We discussed about the bladder neck contracture, which we discussed just now. Number 2 is a meatus. If there is a short meatus, cut the meatus. If you have too much of a traction, this penoscrotal junction, ventral area will get completely eroded and it forms a stricture. Dorsal area of the bulbomembranous junction, which is there just below the pelvic diaphragm, will get ulcerated and that forms a stricture. So too much of a traction is one of the reasons said to be stricture. If at all sometimes you need a traction, it may be advisable to put a traction onto the dorsum to prevent a penoscrotal junction stricture. Yeah, well, bulbomembranous junction stricture cannot be avoidable in this. Your comment on that, sir?
Yeah, no, I agree your positioning of the caster, but what I said was a mild traction, penile traction we call it. Yes, and that is the usual practice, and put it on the abdomen side is better. There is yes, no doubt about that. And even if you do some traction, you can release it after 2-3 hours or 6 hours when patient is shifted to the ward.
I still remember, if you remember correctly, sir.
I like to share you something about this optical ureterotomy because in All India Institute I didn't have the ureterotome. So there I used to do the dilatation, and cystoscopy was mandatory before starting any procedure. But in Vedanta I had a ureterotome, and I tell you, moment I find that urethra is narrow or cystoscope or resectoscope is not passing the meatus, I immediately stop and do a optical ureterotomy. And since I have started doing that, the incidence of the stricture has gone down very significantly, I can tell you that. So
I understand, sir.
Is a good thing. I think so. Every urologist should have that.
Absolutely, sir. And it's all units. Every unit has got their own methodology. Some units routinely do otis ureterotomy. Some units do it as and when necessary. Some units are preferring a dilatation. But overall, individual experience has said that these maneuvers have decreased the incidence of urethral stricture in their own patients. But at present, I don't think there is any randomized control data which ever said that there is an incidence of stricture decrease in one group and versus the other group. That is only one thing which I can say. And the third thing is, whenever the patient comes back into the position when the legs come down, the BP falls again. So beware. Beware two things. Number one, at the end of your resection, you should have a preoperative pressure. The moment the legs are brought back into the supine position, there may be a drop in pressure and there may be a hypotension, and it's again bleeding after the hypotension is recovered. So whenever we do a hemostasis at the end of the procedure, your pressure should be normal. You should check it once the patient is supine and then look for the bleeding. And if necessary, a mild retraction like this is good enough to take out that prosthetic, whatever is there inside the prosthetic fossa, to come out through the by the side of the catheter in the pericatheteric area. That's what Dr. Gupta was talking about, so that it doesn't go into the bladder and clot and then cause the blockage of the catheter.
Malik, what were your cartridge settings?
So this is a prefix setting. It's a bipolar cartridge of Olympus, so it's a prefix setting. It's a prefix setting wherein you choose you have an instrument. You have an instrument. It will you'll have a loop. It will come to that particular setting. That's all. You have a bipolar loop. You will cut to that particular setting. You have a mushroom electrode. You will get a different setting. So it's a prefix setting. This is a setting for the routine loop.
Now, Mallikarjun, you mentioned about mushroom electrode. So that
Yes,
was
sir.
your favorite once upon a time. We have seen several
Sir.
workshops.
Sir.
So what about the mushroom electrode? Why did you use in this particular case?
Sir, mushroom I don't use, sir. I used to use a Nakagawa loop for enucleation on the other side. I used to use a Nakagawa loop before. So that is the actual thing what I've been using most of the time. But of late, the failure of mine is though I devised one technique of bipolar enucleation, I'm not able to make somebody replicate it. So I think it's a failure of the procedure, because that invention has got no meaning when it cannot be replicated.
Correct.
Very good
So
demonstration, Dr. Malik. I think we have some questions from the chat box.
Go ahead, sir.
So-
What I do is, before you'll be discussing the questions. I'll present the next case. I'll go to the next theater for iTIND. What I'll do is I'll present the next case. Present the next case. You have a discussion during that time. I go to the next theater.
Okay, go ahead. And
Yeah, you can read question, Anil.
the questions are that was any this thing voiding trial without catheter was given anytime,
Yes.
Basics కోసం పెట్టాను.
It was given.
and what was the medical management of this patient? Then what is the maximum time normally traction should be kept? Then we have a question that is there any urodynamic study done prior to this procedure in small prostates? What is the recommendation for urodynamic studies? And then there is another question that what is the role of mist in such a small prostate? So we can always discuss these questions. And as Malik has go to the next case, I can...
Moving on to second case. We have a 40 years gentleman with obstructive legs for the past 2.5 years. He is on alpha blockers. Clinically, he has grade 1 prostate. And ultrasound shows 22 cc prostate with a transverse diameter of 45 millimeter. And this is the seroflowmetry picture with a Cmax of 10. Plan for him will be iTIND.
What was his residue?
Hey, what is the reason of going for the iTIND? Why not to continue the medical treatment? Is he objecting for that, or is having complications of the medical treatment?
Hello?
Yes,
Yeah.
Mallikarjun.
Yes, Malik.
Sir, this patient was there on a patient was there on a alpha blockers past 10 years, sir. And intermittently off late, he doesn't want to take it. He wants any alternative medication, alternative treatments. He's only 40 years. So of course, I can think about a bladder neck incision after some point of time. I offered him that iTIND is a possibility for him where the retrograde ejaculation doesn't happen. So he chose iTIND. In fact, of late, I see patients choosing iTIND a significant number of times. And unfortunately, though iTIND was actually described for BPH, our mindset goes according to wherever the bladder neck incision is necessary, like scenarios is necessary, we are selecting iTIND. And most of my usage of iTIND is for less than 40 or 45 years in younger patients with significant obstruction in spite of ALFU. The uroflowmetry you saw is in spite of alfusin, what he was on in the last 10 years, sir. So the iTIND indication here is not want to continue alpha, this thing, not even comfortable with taking alpha blockers. Also, that's the reason why iTIND was chosen as an option given, and he chose for it.
So what is the marital?
I'd like to ask one question. Will you like to do a cystoscopy as an outpatient to decide what kind of mist you like to do?
Yes, sir. Our institutional protocol is to do a transrectal ultrasound and understand the intravesical projection. Most of the time, if the gland size is less than 20, 25, 20 or 25 grams, which is and clinically it is a small fibrous prostate, in which case without intravesical projections, I may skip the cystoscopy. But whenever there is a gland size is a little bigger or any doubt of a median lobe, before we advise a mist, we will always do a cystoscopy to understand what sort of a procedure might be better for this patient, sir. But for this patient, I didn't do. But in general, if somebody wants to choose mist, a cystoscopy, prior cystoscopy is advisable.
Right.
So can you guarantee that there will be
you think that the good imaging is not enough?
It should be enough, sir. That's exactly our clinical examination.
Do abdominal ultrasound, you do in the oblique and lateral view to see about median lobe, and you can do transrectal as you said. I think so. These imaging will be good enough to give you all the information.
I don't deny that, sir. Absolutely. If I do a rectal examination, if I do a what is it? Good transrectal ultrasound, that should be good enough in majority of the cases. I do, in fact. But problem is, I have all the measures of mist. I can do a iTIND, I can do a UROLIFT, I can do Rezum. In some patients, I'll choose my method on the prostate and take care of it at that point of time. So that's what I do in some patients. But if not there, if the patient need to be said what need to be done, I think it's better to do a cystoscopy, make him understand what is he going through, and then choose the procedure, and so that the costings also can be understood by them very well.
I totally agree. I never do a office cystoscopy for a standard BP. Not at all necessary. You can go in and do whatever you need to do. But when it comes to mist,
that's exactly, sir.
Cystoscopy would be very essential, because ultimately, whichever method of mist you are talking about, the median lobe matters a lot, and that has to be visually seen apart from the good imaging that we have. So a preoperative cystoscopy before a mist is, I think, necessary.
Hello?
Yes, go ahead.
Hello?
Yeah, Malik, there is a question. Any place of...
Sir, I'm going ahead with the cystoscopy.
Prostates.
Yeah, you do the cystoscopy. Let him proceed with the procedure.
Yeah. Well, I think, sir, that is a very important question. Sir, that's a very important question. Role of urodynamics in this sort of a small fibrous prostates. Well, I would do that if I have even an ounce of doubt of any neurological illness. Suppose if the patient is just 25, 30, 40 years without any neurological things, no constipation, thick bladder, tuberculated bladder, no post-void residue, but a very poor flow rate. All these things show no evidence of detrusor dysfunction. But any of these things are there. If there is any doubt of detrusor dysfunction, we have to think about urodynamics. And in all these patients, I do the urodynamics on the day of surgery or the previous day of surgery. If there is a high pressure obstruction and do a urodynamics, these patients go into sepsis. So I always tell them that you come for a urodynamics, we do the urodynamics, and then I'll do the surgery in the same day afternoon or the next day morning. I'll never give them time for in between at all.
Agreed.
So another question, Malik, is that preoperative cystoscopy should be done under local or under anesthesia.
That's exactly the point what I was talking about. Majority of the times, preoperative cystoscopy done under local anesthesia gives a very false appearance of the prostatic urethra. We majority of the time see in a local anesthesia when the pelvic floor is very tight and the patient is when keeping the pelvic floor tight, the prostatic urethra appears as if it is a grade 2 one. The moment you give anesthesia and go inside, you see a grade 1 prostate only. So that's another reason why I prevent a preoperative cystoscopy unless otherwise it is mandatory to assess what sort of a mist I'm going to take out.
Right. You just did a quick scopy.
So,
and we realized that there is a soft proximal bulbar stricture there, which
Yeah.
you
very,
just
very
gone
soft.
through.
That is just the 17 sheath. It's only 17
Yeah,
sheath
look
is
at
gone very easy.
Yeah. So there
Yeah.
was a stricture, small stricture.
I don't think that is the reason for obstruction, but he's been there for 15 years. So it's a almost normal bladder and a grade 1 area only. So what I did now, I can't even call it as the same thing. If you look into a cystoscopy under local anesthesia, you will have a high riding bladder neck. This is what it's going to be. Once I've given an anesthesia, it will not be high riding bladder neck. So what I'm going to do now, I put my 17 or a 19 sheath inside. I'm taking it out, half filled bladder, and I'm going to take it out and let the bladder be there. And then this is the iTIND device.
Can
This
you
is the
zoom in?
iTIND device which has
Can
come.
you zoom in?
Got it?
Yep.
Yeah.
And this is covered inside. It is inside in a sheath. And this is the stellate rod with a thread inside. So this 12 o'clock position, it has got a tri-radiated leaflets, which one goes to the 12 o'clock, one goes to the 7 and 8 or 5 o'clock positions, and then there's a leaflet which comes in front of the verumontanum to make it stable. So this is the way the whole prosthetic urethra gets stretched away. So for that reason, where is that leaflet? This leaflet is there in a 6 o'clock, and this blue line is on it, is going to be showing it as a 12 o'clock. So this will guide us, saying that at what level the leaflet is going to be there, because your vision may be little difficult once it is there in the prosthetic urethra. So what I'm doing,
this is very small prostate, and the leaflet is very big. That is around 4 to 5 centimeters. What is the size of the leaflet versus size of prostate? Does it have any difference?
That's it. You see, at present, the iTIND variety is going to be one fixed size of a 3.3 or a 3.4 centimeters of size. It's not the leaflet. It is nitinol wires which are there going to be 3.5 centimeters. The leaflet is going to be 2 centimeters in front of it. So the leaflet will be coming towards the verumontanum. If there is a smaller prostate, rest of the whole thing will be there inside the bladder.
And suppose a very large prostate more than 3.5 centimeters?
It is not indicated.
Not indicated.
So what I'm trying to do, I'm trying to push the whole thing inside through this sheath with the stellate inside. The resistance, because the sheath size I've selected is smaller. And then once it goes into the bladder, yes, there is a release which happens. So it is gone into the bladder. I come out with it now.
This you are putting through cystoscope?
Yes, sir.
No, okay, you have taken it out. Okay.
I put through the cystoscope only, and the same cystoscope I use it to pass it by the side now.
Is 17 or 19 French?
Sir, 17 also it goes in, sir. They advise 19, but a 17 also it goes in.
It goes, okay.
The blue thing has to be at 12
At the roof. At the roof. That is the roof. Yeah. See that? You see the 3 nitinol studs which are going to be there at 12 o'clock, 5 o'clock, and 7 o'clock, and a leaflet which is there in front of it, which will be fixing it into the prosthetic urethra. So once I see that, a little filled bladder, I come out into the urethra in front of the verumontanum. It requires a little pull. It's a significant pull. It's not a simple pull. It's a significant pull which is necessary to push it inside. So I've got it into the urethra. Now I see where that leaflet is there. It's a very significant pull what is necessary. Yes. So I have to see. It's a little difficult thing. This is the only difficulty to understand whether we have placed it correctly or not. That is the only difficulty. That's a verumontanum here. I think I still need to pull it. It has not come in. Yes.
So the pressure you apply means aims at cutting.
See that the leaflet is in front of you coming like this. That's a leaflet. I'm pulling it into the.
So yes. The angulation of pushing is important.
Yes, see that? It is there in front of the verumontanum. You saw that now?
Yes, we can see that.
That's going to be there in front of the verumontanum. So I'll readjust it. I've just left it like that, and I see that again and see whether I'm in place. All these wires are beyond the external sphincter. We presume that it may cause significant incontinence, but it doesn't happen. You may have a little urgency and urgent continence initially, but it doesn't be happening continuously. That's some sort of I don't know. I was looking at a mucosal cavitation as a necessity for causing incontinence, but it appears that it may not be needed also now. See, that's a leaflet in front of the virumentanum. I'll show you again. Yes. Yeah, see that? The leaflet in front of the virumentanum, fixing the virumentanum. Saw that?
Yeah, nicely
Yes,
seen.
yes.
Okay.
Right?
Good.
So I'll
good,
leave
good.
it there. I'm pushing it there. I'm leaving it there. Once I leave it, I come out. It's there in the roof, right? I leave it. Now, I'm taking it off.
Have you
And
tried to see it using a ureteroscope?
Well, it can be seen. The best thing is going to be a
Because with
PCNL
ureteroscope,
mini perk nephroscope, sir.
okay, because you could then enter the bladder and come see it as you come out.
Sir, that's a mistake why people should avoid, sir.
Why?
Trying to the leaflet into the bladder sometimes displaces it and rotates it.
Okay.
See, the biggest negative point of an iTIND is let it be pulled into the ventral aspect and keep it at the ventral aspect. Displacing it, rotating it again out towards the lateral aspect, you cannot get it to the center again.
Okay.
You need to end up in taking it out completely and again reloading it and pushing it. Sometimes, day before yesterday, I did a case. I had to take it out because of the same problem. I had to take it out. Sometimes it can cause urethral injury. Majority of the time, still now, twice I have done it, it never happened. So once it is in position, don't try to get inside by the side of it or into it. But that will rotate the iTIND completely into the other side, and the leaflet, which is supposed to be in front of the virumentanum, moves towards the lateral aspect, and it cannot be brought back into the same position again.
Good point.
Correct, sir? So I take it out.
Malik,
That's it.
which scope you feel better, 0 degree or 30 degree?
Sir, in fact, I would prefer a 30 because you won't see the leaflet in front of the verumentanum well. If you have a 0 degree, you might not be able to clearly visualize that. And under anesthesia, I give some sort of a suprapubic pressure to empty, because this the reason why is sometimes, very rarely, if I do it under spinal anesthesia, patients may not be able to perceive the distension and they may go into retention. Treating a retention is a headache after iTIND. You may be able to save infant feeding tube through the loom. Sometimes you may not be able to pass the infant feeding tube. So beware of it. In fact, in our whole series, there is one patient where we had to do an SPC, because we could not do pass a catheter either in a cystoscope or through this anyway. So it got fixed so much. That's the reason why we avoided it. So this is iTIND, where I press all the suprapubic area so that all the urine inside the bladder has come out completely, so that once he is out of general anesthesia or spinal anesthesia, he should be able to pass. So this will be folded and kept in front of the skin of the penis. And the removal is not a big thing. This will be taken into a 20 French silicone catheter with the tip which is cut. Pull it directly. Let it go towards that area, and tugs it against the device and pull it. It gets crumpled and got into the catheter, and you can take out the whole assembly of the catheter. Patients may complain significant pelvic pain. Sometimes they may have discomfort, urgency, frequency. Only one occasion, there are some surgeons who use cortisone very regularly post-operatively for the next 3 days or 5 days. Only one patient of mine where I had to use cortisone because of lot of pelvic pain, what he was complaining, but majority of the times they do settle with a smaller dose of diclofenac or some other non-NSAIDs only. And result-wise, two things will happen. Number one, I have 80% of my patients who have a better flow rates even without medication. There are 20 to 25% of the patients who have a same flow rate, but the patient is happy. He feels that he doesn't need to strain to pass urine. There is a 1 or 2%, my follow-up is still short. I still say they're feeling the same. They're not really very happy, but I don't know. My estimate of my dead to serve function in those patients might be wrong. That's the reason why we don't have a good result. We scoped many patients post-operatively, and we see a good triangulation which happens in the first week or second week, but we never scoped anybody after 6 months till now, because unless they come back with a complaint, we didn't want to scope them. I do a flowmetry again every time after 1 month, and I put them on alpha blocker for a period of 3 to 4 weeks and then stop the alpha blocker after that.
You have a
But Cartoon,
clip.
if they fail to pass urine, what you will do now?
I pass the infant feeding tube by the side, sir. Majority
Already
of
you
the time.
have put in this case. No.
No, I haven't put, sir. I haven't put.
Malik, do you have a clip to show 2 weeks later post-TIND?
Yes, I think we have, sir. I think during this time we'll do it. Suraj, that last clip is there. Post iTIND take out that. The next case is
we
over.
would like to see a pre-op.
Pre-op and post-op. You have it, right? Show it now. Show it now. You have a video. Take it out, that video, and keep it, and we'll show it. We'll show it, sir.
Okay, thank you.
Then you have a discussion. We'll go to the next case. Next case presentation, please. We'll go to the next case, sir.
So thank you, sir, for showing UROLIFT. I request moderators to take questions. There are some questions in the chat box. Gupta sir and Kripekar sir. Before we start the next case is TURP. Yeah, you can tell about the case.
Yeah, you can give the
Next, we
details.
have a 75 years gentleman with hypertension presented with obstructive LETS on silodosin and glutathione. Clinically, he has a grade 2 prostate, and ultrasound-wise, prostate is 63 cc with a transverse diameter of 50 millimeter and PER of 65 ml. Qmax was 8. And plan will be bipolar TURP.
Who's going to do it?
Hello?
Hello?
The devil is back, sir. Who's going to do it? Devil is back.
Now we can hear you well. I don't know what was happening in the
I
first.
don't think there was some problem into it. I don't know. Able to hear. We don't fail usually. I don't know why this guy messed it up today this time. Don't fail usually. Yesterday we had a trial also.
But now it's absolutely
Now it's clear. I think very nicely audible.
So I've done a cystoscopy, there's a receptoscope, and then there is a.
You don't have endoscopic view, Malik?
Yes, sir. Endoscopic view, please. You got the endoscopic picture?
Yes, we have.
So I think I've spoken about the ergonomics when we start looking at the TURP. We have done that. So the cables, how to be distributed, and we have kept it. And then I did a cystoscopy. So once I do a cystoscopy, what is happening? Well, right. See that? You are able to see the endoscopic picture?
Yes.
Yeah, clearly.
So that's a fairly decently big gland. And that's a verumontanum and the pelvic floor. Right?
Yes.
Right. So that's what I was talking about. When I keep my scope and see, Puncham. Camera cleaning, something here. Okay. Now, okay, fine. Okay. So what I was talking about at that point of time was, if I need to put this sheath into the bladder, see my resectoscope position. So this position is not correct because you're holding like this and operating, it will not be proper. So whenever we have a problem like this, what I do is head and down, please. Head and down in such a fashion, yes, so that it becomes flat. It is just horizontal, so my work is going to be better. So saline on, rest a little, rest a little. So what I'm trying to do now, probably the standard Nesbit's method. So you have a grade 2 prostate, the lower portion of the prostate is enlarged here, the upper portion is there enlarged here. I don't see a median lobe, but I see a little higher bladder neck area. So the steps are number 1. Number one, we need a proper irrigation to go into the bladder. You can still see that irrigation is not flowing. So the proper irrigation is going to be once we make a channel so that the irrigation flows very easily. So the proper irrigation has to be channeled by resecting this area or resecting a median lobe if it is there. That's number one. Number two, how do you plan a resection in this prostate? Where is the mark? This is the pelvic floor area, and this is the, you see this, what is the movement, what is happening? That's all is the length of the smooth muscle. What is moving right from here till that point is something, a movement happening. So this is all the density of the smooth muscle which happens under the mucosa up to this point. So we need to preserve as much length of the submucosal muscle from here down to verumontanum. That is the idea to in this resections. Okay. So what I do now, a little table up. Okay, the planning of the lateral lobes. Let me resect the place in the median area so that I can have a flow of the urine, flow of the saline which goes into the bladder freely, so that my vision is going to be very clear. So what I'm trying to do is small cuts into the bladder neck area. Into the bladder neck area, you saw the circular muscles already. This is the vesicoprostatic junction here, and this is the prostatic tissue here. So take out a little amount of prostatic tissue in front of you at a 6 o'clock position, just at a 6 o'clock, so that the ability for the saline to go into the bladder is very good enough. So that's what I've done. So I'm fine with it. I don't need to resect. That's very well flowing now. So how do you plan the resection? Empty, please, empty. How do you plan the resection? So for everything, we need to plan the way you need to resect. For a proper TURP, how do you plan to resect? So there are three ways. Okay, let me empty it. Pressure. So I'm put them now. Okay, so what is this? There's a prostate here and prostate here. So there are three steps of prostatic resection. Number one is going to be making a cone. That means create a cone from here point till this point, and then say that the majority of that area is depulked. Number two, second step is going to be excavation. That means prostate is not flat, so it will have it will have some sort of a concavity here on either side. So excavate that from that area. Number three is the apex. So there are three ways of looking at it. Your comment on that, sir? What I said?
Yes, I think what you said initially to create a channel for a flow of the fluid is perfect. It has to be done. So I would make that channel a little wider.
So I would start in a, yeah, it will be wider, sir. It's not a very big prostate. I can think about doing it of now itself, but I thought it's okay. So that is the channel what has been created. The arboration of the vessels. Once you see the arboration of vessels happening, arboration means you see these vessels running around, running like a flat. This is what means this arboration means you are reaching the capsule. So beware. Stop there. Stop there. Once you see the arboration like this, you stop it. It is a compressed with corkscrew compressed and go and run between the capsule and the adenoma. So that is an arboration of the vessels. I wish I would have taken a continuous sheet. The urethra was a little narrow, so I thought I'll use a. Okay, so now the next step is going to be making a cone excision. So I start my resection at around, say, like what Nesbitt said. Think about the main vessel which enters into the prostatic tissue, that is in junction between the vesicoprostatic junction between the bladder neck and the prostate at 11 o'clock and a 1 o'clock positions. So these are the one artery which is going to be there. I haven't seen it yet. Possibly it got already coagulated. So that's a thing which is going to be there. I identified the sphincter where it is there from here till here. So I don't want to go beyond this point. I want to retain this amount of the smooth muscle under the mucosa, even in front of the verumontanum up to this point. So my resection should not cross that area. So when I'm making a trough at this area, this is going to be 11 o'clock area, I may get that vessel, it got coagulated. I see that the coagulation is done. The next vessel is going to be seen is going to be at a 4 o'clock and 8 o'clock or a 5 o'clock and a 7 o'clock. Those vessels are going to be going between the bladder neck and the bladder muscle and the protic. Both the vessels I could see it. Probably it got coagulated, but I didn't see it. But anyway, now I'm not really looking for them. I made a trench and right up to the capsule in that area, I presume. So I'll start doing that now.
Malik, your camera is not fixed because when you are resecting at the level of flocks at 11 o'clock, we
Yes.
see it, you are resecting at 6 o'clock.
Okay, it is a fixed camera, sir. You want me to see as if you're looking at 11 o'clock, then I do this.
That's
a pendular camera.
That's how the
right?
orientation should be. When you are
No, I
resecting
got
at 11.
oriented in a different direction. I got it fixed. This is a pendular camera. Wherein, you see, that's another problem, sir. If you see, I see majority of the people holding like this and holding the camera and keeping it fixed and rotating it like that. Instead of it, use a pendulum camera. Fix it and then rotate it along what you have seen till now, or unlock it, let it stay here. The disadvantage is by staying here, when you're rotating, you may shift the camera position also sometimes. The second point, people forgot how to hold the resector scope. People are holding the resector scope and holding the camera doing this way. Is the correct way. You're going to have your little finger on the pubic symphysis. You're going to have your instrumentation held on the left side along with penis. The reason why is, suppose you come out into the urethra, into this area and started resecting in a bleedy structure, your little finger is not onto the pubis. That will suggest you, damn it, you're not onto the correct area. So this is a guide which will tell you where your resector scope is. This is the actual way it was described to hold a resector scope. You can manipulate your saline, you're going to hold it. And second thing, for excavation, I would say the left hand is a dominant hand. If you want to excavate the tissue like this, your left hand is the dominating hand. That's the reason why I would say people have to get used to a pendulum camera without holding a camera and rotating it as and when necessary. You got my point, sir? How do you say? What do you say?
Yeah. No,
Arjun, I like to interrupt because I am using a fixed camera, and then I am very comfortable. I know where I'm working.
You're expert, sir.
So
You're a leader and expert, sir.
Thing, and I have a full control on my camera all the time. The
Yes,
second
and
thing
you
is
can
about the resection of the 6 o'clock. Yes, I agree. But if there is a large median lobe, then I have described my technique in the YouTube. Their videos are there. I start at 5 and 7 because these are the main bleeders are coming from here. I devascularize the median lobe and then I quickly resect the median lobe. Same, I start at 11 o'clock and 1 o'clock and then make it truce and then we resect the lateral lobes. So that is the technique what we are following.
Perfect, sir. You see, I've done a trench in the 11 o'clock position, which has gone right up to the capsule. See that I can see some capsule fibers and gone a little ahead of the capsule also during my talk. And then now I see that this is the lobe which is there in front of me. So I start dissecting. The tendency is the two ways of resecting. If you are an expert, you start coming along the capsule and start going along the capsule. Oh, that's an actual bleeder which is there. So that's an actual bleeder which is supposed to be there. It has come in a lower level. So you start going on dissecting like this all around the capsule. And then what will you have at the end? A devascularized lobe here. But I think for a beginner, I would say instead of going ahead like that, you start resecting it. I'll show you the positions 1, 2, 3. Once I take it out and empty the bladder, I had to empty the bladder because the urethra is small. So I didn't want to put a 26 sheath. Okay. If I look at, if there is a resection, it can be that you go on going along with the capsule and go right up to the bottom along with the capsule and then like this, 1, 2. So 1, 2, 3, coming down to the 6 o'clock. So that is going to be a little tricky for a beginner. So what I would say, you take this vessel which is there at 1 o'clock initially or 11 o'clock initially, and then start moving your thing. 1, you come. Number 2, you're going to take out the tissue and make it flat. Make it flat. So that tissue, what is there in front of you, is being resected. So you don't have a devascularized lobe. It continues. So you start resecting it here, and then you take out the tissue which is there in the center of the field. Your comment on that, sir, for a beginner to resect?
Yes, for a beginner, this is the best way to go. I don't like that beginners should go to the capsule right in the beginning, because unfortunately, if they perforate a capsule and open a sinus, then you have no option but to quickly get out of the situation. So gradual resection as you come down from 11 to 6, or that would be the right way of doing it for beginners.
But for the beginners, I will say the other way around, because they can start at 6 o'clock and then they can go up on one side and they can go up on the other side.
But
So
it's
that
a
is more
gradual.
safe.
Perfect,
And
sir. Perfect.
that is described as a step ladder pattern of resection of the prostate. So where you
Absolutely,
go on
sir.
cutting what you see in front of you and step by step. But if you want to do really a large gland, I think so, then you have to control the bleeding first. That is my concept of the anatomical section of the prostate, right?
Perfect, sir. In fact, I would say that only for a beginner, you start resecting from one end, go to the other side, take the ridge away, again rotate, take the ridge away, and start moving.
Only one message I want to give is they should resect only one lobe at a time. They should not do one cut on the left lobe, one cut on the right lobe, then it will be mash up everywhere. The bleeding will come from here, there. They should focus one lobe at a time.
Yes, sir. That's true.
Yeah.
So what I did now, I made a...
There is a question, how does undermining happen near bladder neck?
That's because of trying to flatten the bladder neck. Never try to flatten the bladder neck. Once you see the circular fibers of the bladder neck, after resecting some amount of tissue, just stop there. Don't go beyond this point. Once you go beyond that point, you'll start undermining the bladder neck. No doubt about it.
And if you have undermined...
No, in the first case, Mallikarjun has very nicely shown the area of the bladder neck and the junction of the bladder neck and prostate. So that is the junction where usually undermining takes place, actually, And some triangulation can also, if you are now putting the instrument back and by mistake you can go inside. So some triangulation is the problem which can happen if you resect too much in that area, actually, in the beginning.
Yes, sir. Absolutely true. So what I did till now is I did that cone which is being created at the bladder neck to a part of the mid part of the prostate. That's a cone which has been created. I took the vein vessel which is seen in front of me. Seeing a little fat, I possibly went a few millimeters little on this side and seeing a little few fat fibers there, these lobules there. So that's a cone which has been created I was talking about. After the cone, there are two things which are going to be there. One is an excavation, another is apical release. So the cone is being extended towards the verumontanum. I'll extend the cone towards the verumontanum step by step. Like I would prefer what Dr. Gupta said just now. Come to the 6 o'clock, move towards the 12 o'clock slowly. So come to the 6 o'clock, move to the 12 o'clock. I'll show that what he was talking about. So 6 o'clock, I made a cut here. And the next cut is going to be this ridge, half loop, and this is cut. And the next cut is going to be this ridge, half loop. You know at what level it is going to be there. The next cut is going to be a half loop and cut. And the next cut is going to be this way. So go right up to the top again. Once you finish the top, you reach the top there. Again, the same thing will restart. You start cutting again half loop, take out that cone, again half loop, take out that cone. Again, that ridge is cut. So what are you trying to? You flatten out all the ridges what you have created. At the same time, you are seeing any vessel which are going to be burned, and then you are not reached the capsule, but you are slightly debulking the prostate. I think this is probably a better way rather than looking at it as it's a combination of what Nesbitt has taught you initially, and then later after understood the anatomy and very well understanding the anatomy. So that's how you start doing it. Your comment on that, sir, Gupta sir?
No, one thing more I want to just say that we should divide this prostate into 3 zones: proximal, middle, and the distal close to the verumontanum, the apical lobe. So that if you start with the bladder neck area, and then you can do the middle part, what Mallikarjun has just shown you. And then when you come close to the viru, then you have to be very, very careful not to come out of the sphincter. So like that also one can plan. But one thing is very important: after doing a cystoscopy, surgeon must make a plan how I want to do this particular gland. And he should stick to his plan.
Hello, sir, Malik sir.
Yes.
Sir, you doing it so nicely. You're an expert receptionist. For the sake of postgraduates, can you tell us something about what is the standard cut, extended cut?
Oh, no, I didn't get the question.
So can you show us what is standard cut and what is extended cut?
Extended cut. Okay. What are the types of cut? There are three types of. If you are a beginner, everything is in front of you. Your hand, your finger, everything is in front of you. That's it. That's it.
Okay.
If you are a little have a little experience, longer length of the stick, longer length of the loop, which is around 2.5 centimeter. If you are a Guptaji Sarka, you take
Yeah,
that, come right up to the verumontanum, see where you are entering. This is extended cut.
Okay.
So whole prostate coming out in this matter at a 2.5 centimeter, more than 2.5 centimeters. So you're moving your resectoscope in such a direction that it extends this length of the chip. So there are three types of chips. One is a smaller than the loop length. Another is as much as the loop length, and third thing is more than the loop length. So these are the three ways of doing the cut.
Yeah, okay. Thank you, sir.
see, I like to add here something more, that when you are seeing what you are seeing, that is only you are resecting. One thing is very clear in the mind. If you blindly cut somewhere else, then there can be a problem. And what the extended cut is, when you are moving your resectoscope sheath along with the loop, that is called the extended cut. And extended cut should only be done by the experienced person, number one. And second thing is, it has to be a large prostate. If you do in a small prostate, you can come out and you may cut the sphincter area and all that. So you have to be very experienced for the extended cut. In the beginning, first 20, 30 cases, you may do the standard. And later on, you can start doing the extended cuts.
NP,
Here I'm not doing an extended cut, sir. I'm doing a routine cut. That's all.
Yeah, you are doing routine cut. I know.
I'm fixing my resectoscope. I'm not moving the resectoscope. My resectoscope is in a fixed position. What all is going to happen is going to be my the loop length only. And I was talking about, there is one thing I see, most of the time people start doing is, everybody thinks that the right hand is a active hand in resectoscopy. No, in fact, right hand is much more passive. Every part of the movement is done by your left hand. I'll show how and why. This is what happens when you have finished your conization. That means putting a small, resecting the cone or tissue of the prostate from the bladder neck, etc. Let me see, there is some bleeder which is bleeding. And then I'll come back and I'll show you somewhere here. Okay.
The statement Dr. N.P. Gupta said is perfect. You resect what you see.
That's it.
You don't imagine and resect. You must resect what you see. Another, I will make a point on extended. It has to be done by very expert people. But one of the causes for primary post-TURP proximal bulbar strictures is an extended use for resectoscope, extended cuts, because you tend to pull out your resectoscope into that pelvic fossa area, and all the resectoscopes have perforations for Iglesias method, and that's what rubs onto the pelvic floor area, which Malik has demonstrated clearly.
Cheese grating effect. So that's exactly the second point. Now I want to tell about ergonomics. You see, you need to keep the fulcrum at the bulbomembranous junction. So the resectoscope doesn't move too much. Your fulcrum should be at the bulbomembranous junction, and the resectoscope should move antero-posteriorly or laterally. This will protect the sphincter. If you go on moving like this, people tend to move like this. You tend to have more incidence of stricture. The second thing, what I was talking about, passive hand of the right and the active hand of the left. I'll show you how it is. You see my loop, I'm keeping my loop passive. I'm using my left hand to move the resectoscope to make a scoop here. My right hand is not moving. My left hand is moving to create my loop. See that? That's the reason why I say in majority of the urology procedures, it is the left hand which is active, not the right hand. You do a PCNL, it is the left hand which shows you where the scope is going to go, not the right hand. Right hand is going to hold only the stone. Whereas you do a TUR, it is the left hand which shows where to go. This is what I say. You need to keep your left hand very, very dominant, and the movement of the left hand will decide how to go. Am I right, sir? Comment on that.
Yes.
Yeah, you are absolutely right. Now, if there is a question how to plan an incision if prostate is extending beyond Viru, that lisosphincter is not compromised.
Sir, Malik sir? So
Hello.
Malik sir, it is said that the shape of the chip should be boat shaped or canal shaped. Can you tell us how to take that kind of chip?
Which one?
The shape
didn't
of the
understand.
chip, resected chip should be boat shaped or canal shaped.
That's what exactly he was talking to you about, the use of a left hand.
Left hand. This is what scooping is left hand.
Correct.
This is what
That's
I'm
the
saying.
use.
See this, my left hand. See the left hand. The scooping happens because of the left hand, not the right hand. Right hand can never scoop. Right hand will make the loop move up and down. That's all. It is the left hand which creates that scoop. It moves all across. That's called excavation. What I did till now was coning. I coned the majority of the prostate. In fact, I came out of here and see the fat here. I was a little reluctant and a little missed my concentration and over resected here when it was not clearly seen. But anyway, that is the point. But
We've lost your
We don't
endo
have
image.
endo
Malik,
view, Malik.
we have lost your endo image.
Endo image. I think you'll get it.
Yeah.
Right? So excavation is a part of your left hand. This is what I'm excavating. So what I did till now, I finished the cone. I did an excavation on the left hand, on the right lobe. And what is left behind is apex part. I don't do the apex now. I finish the left portion and then come back to the apex. What will happen is you tend to do the apex and you mess, something happens. You will. The idea is to preserve this smooth muscle right up to that point and take out that fat, take out the prostate, what is there next to it. That is going to be the next step of my resection. I almost did my excavation of the right lobe completely. At one areas, I went across into the little amount of fat also. Little small areas which is there, I can do it at the toileting at the end, not now. So whenever you reach these areas and there is still some small fat, some tissue left behind, wait for the last. That's called toileting. You can resect them at the end. Don't do it at this point and end up in going into the capsule or outside the capsule and get into problems. Am I right, sir?
Yeah,
Yes,
apical
yes.
tissue should be handled at the end, in this particular.
The rest of the coning and excavation can be done at this point. Reach the capsule as much as possible in all the directions, as much as possible. Don't try to reach the capsule at every place at this level. Stop it at this moment and go to the other side, finish it, and then come back and take care of the apex. And the last process is going to be called toileting. So I've reached the capsule here. This is all the white listening area capsule. This is all his capsule. I don't think much tissue is left, but I'll take it at the end. I'll go to the left lobe. So we will talk about Nesbitt's way and going up and down and taking out from the other side. Okay, come back, look in. And most of the time you see the bleeders here only. You will not be able to see that. You will see that now. Take care of those bleeders in the roof, what are there. Okay. Which have been there. Okay, now come back. You know to know the idea. So you have a verumontanum here. That's a veru. Now rotate the receptoscope, push a little ahead so that you will not come towards the sphincter area. And start resecting and start creating a trench in that area. At 1 o'clock. So I'm creating a trench in 1 o'clock, trying to see a bleeder. Yes, the
that's where
bleeders
you're
have
going
come.
to hit the artery of flock.
Yes, that is both have come. And the way to coagulate, push it on the side. Don't put it on the top. Push it on the side. Push it on the side. That's how it has to be. It has to be coagulated. Putting on the top makes it visibility come a little less. So push it to the side. Am I right, sir?
Yes.
Yes.
Now
yes.
I start resecting. This is what I was talking about. Once you know the capsule, you start resecting the lobe now and go to the center. So from above downwards, you start moving from above downwards. So you know where you are. So this is what is a conization. So I'm resecting and creating a cone at the level of bladder neck and retaining the tissue, rest of the tissue for excavation at a later point of time. Which is supplying at a 4 o'clock and 8 o'clock position. So again, I'm saying for a beginner, I would say, come back. If you are able to see this loop tissue, divide it, debulk it, and then once you are debulking, it is a conization. It is, you are creating a cone from the bladder neck towards the verumontanum. That means there is a lot of tissue which is left towards the capsule in the concavity of the capsule. So we are creating a cone. I'll show you how the cone looks like at the end. So this is the main portion of the debulking part of the prostate.
So Malik, have you ever used a suprapubic needle or a cannula?
It doesn't work, sir. Often they get blocked because it's a gluteus cannula was a biggest failure because it was very well used. But what happened is all these chips used to go and block that, and it never drained. And people started feeling that they are safe because of the problem without anything, and they started going on dissecting. Ultimately, people had some amount of extravasation in the suprapubic areas, and they had suprapubic, retropubic collections also. So I think nobody is using it very often. Even if
What
there is a
about
patient who is
a
on an
needle?
SPC.
What about a needle around 18 or 16 gauge needle?
I don't know whether it really makes a difference. 18 gauge needle draining the force, what we are thinking about. Instead, you have a continuous sheath or frequently empty it. That's all. Deepak sir, I think you're fine with the orientation of resection, right? Now,
Yes, yes.
because
Now
this is
Malik,
what
we
I
see
would
a lot of bubbles
say.
during the
Everybody
resection.
should have. See that is bipolar, sir.
Yeah. So
Bipolar, you end up in having
any
some
way
bubbles.
to
Every bipolar,
minimize these bubbles?
the disadvantage in a bipolar is the presence of a bubbles. That's a disadvantage.
No,
but you get into the bladder and you rotate your scope, it disappears immediately.
Yeah, it disappears, but it gets generated. So what I did, you see that cone which has been generated right from the bladder neck area towards it. But you see a lot of tissue which is still there on the lateral aspect of it. A large cone is created. Don't spend too much of time on coagulation. Once it is done, some more debulking in the apical area is in the lower half is necessary. As Dr. Gupta was talking about, it's always good in this sort of a gland to divide it into 3 levels: the upper level, the mid level, and the apical level. I have done the upper level, and then now I'm doing the mid level. When you're doing the mid level, this is what you practice. Your debulk, you see the next half, create a ridge, cut the ridge, half loop. You are going towards the capsule. You see my left hand, the left hand is moving, not the right hand. Right hand is passive. Left hand is moving.
Malik, if you move your hand slowly, using particularly a bipolar, do you think you will have a better hemostasis? Does the speed of your action matter when it comes to bipolar resection?
The plasma is there, the coagulation effect is going to be better. The faster you move the loop, the bleeding is going to be more. What happens is, for a beginner, that is always, see that I'll show you. Your point is very well. I'll show you. I am moving it very, very, very slowly. You'll see a good hemostasis.
Yes.
Right. You'll see a very good hemostasis whenever you see it very, very slowly. So the hemostatic effect will be much, much, much more better.
So would you advise the newcomers who are using bipolar to go slowly?
Yes, of course, sir. Of course.
Yeah,
What is it is we are
with your expertise, it doesn't matter.
Yes.
Speed you use.
I understand. I absolutely say that what your point is very well taken. Start using. If you are taking a bipolar, use it slowly. Use it slowly. You reach the shining capsule here. You see the arborization of the vessels. Don't go on buzzing all these areas. Just see the specific points which are there and buzz it. And then now your excavation part will go on. Excavation part is always a half loop part. Start doing it. I'll empty. And then come back to the this thing. Let me finish it up a little faster so that we can go to the next cases.
Okay. Can I interrupt here now a little bit?
Sir, go ahead, sir.
Yeah,
Please go
the heat generated in bipolar is much less in comparison to the monopolar. That's why what Mallikarjun has said is very right, that if you are using a bipolar, the secret is you have to move slowly. Let the glow comes first, and that cuts the tissue actually. And you have to be slow if you want coagulation. If you are too fast, there will be more bleeding. So initially in bipolar there can be more bleeding, but ultimately the bleeding is less in bipolar if you are using it correctly. The second thing is in monopolar the current is high, so that's why it coagulates fast.
Second thing, sir, most of the time people who are shifting from monopolar to bipolar end up in losing lot of loops initially. The reason why is, in a monopolar, the tendency is to jam the tissue and then start the current. But in a bipolar, you need to activate it first and then start moving into the tissue.
Correct.
If
That
you
is
have,
the right way.
if you have jammed the loop into the tissue, what will happen? The current dissipates and the orange plasma will not be generated. So that's the reason why whenever you're doing it in a bipolar, you need to activate a milliseconds before you contact the tissue.
Yeah.
Malik, there is another problem. The chips keep falling back into the prostatic urethra. So what do you do for that?
There's nothing you can do, sir. Only the flow of the water will take care of it. Instead, I said, you see, indirectly I'm doing one maneuver. You see that I cut the tissue. When I look back again, I am pushing this loop into the bladder. So this is a maneuver which possibly every seasoned resectionist will automatically develop. If it doesn't move, you move it across. That's what most of the seasoned, they don't understand that which is happening automatically under their hands, but it happens. Am I right, Deepak sir?
Yes.
Yeah. So I think for the beginners,
we don't understand it, but it happens.
Lesson.
Very true.
For beginners, that is a point to be taken, saying that when you are looking back, you are getting back the loop inside into the bladder, see that the whole thing is moving the chip also, like that way, going off.
Yes, you are
and then recut again, going off like this. Yes. Spontaneously, you need to develop that small patience to move that loop, right? You saw that happening very, very effectively.
Sir, Malik sir,
Sir,
sometimes the chip doesn't get detached when you cut. What will you do then?
most of the time in bipolar, you are on till it detaches. Most of the time, people switch off the energy much before it detaches, so it doesn't stay, it doesn't get stuck. So that is the problem with monopolar and bipolar. Monopolar, the heat in the loop is still existing, so even if you cut off, the last part of the cut can be happening because of the heat. But in bipolar, it doesn't happen because of that reason. So you need to keep that on right up to the end. I tell you one more modification I always say. People tend to, see, this is we are coming towards the apex. We don't want to move this inside. So I'll show you one modification where I think my unit guys do it very, very often. How do we cut the loop cut the chip at the level of apex when I don't want to move my resector scope behind? So what I'm doing now, it's okay. This is a sphincter and this is the area. I don't want to go behind and I want to keep like this. So what I do, I cut it. Instead of moving down, I move it this way. So the thing cuts away. See, you rotate the resector scope, it cuts away. So instead of moving backwards, rotate the resector scope, that chip will cut away. So that you are preserving that length of the mucosa on it. You got my point?
Yes. So would that create a flap?
That will create a smooth flap which is existing, so that you're not cutting away the tissue. That's a way to.
That's a good point, Malik, and I think preserving the mucosa of the apex is very crucial.
This we need to do.
So that is known as.
So whenever you're doing, what will happen? You tend to go and then rotate it. It cuts off. Tend to go and rotate it. Rotate towards you, clockwise direction. It cuts off. So you don't need to move you backwards. That's it. You don't need to move backwards. That's the way to do it.
Yeah, you're demonstrating it very well.
Very nicely demonstrated. And many prostates, you have lot of apical tissue distal to Veru. So what is your tips for the youngsters?
That's exactly when I come to the apex, I'll do that, sir. Anyway, there is a little amount of tissue around the verumontanum. So what I've done is an excavation here. I'm finishing off my excavation from the thing. What I'm showing this rotation, what I'm saying, where I'm not withdrawing it, but cutting the chip at the apical area. That's a rotation what I was talking about.
Yes.
Clear. So that will retain as much amount of muscle as possible under the mucosa. So I'll come to the apex now. I almost did it, I think. Excavation, I'll just check it whether there is something left behind. I'll just check it. Get Dinesh ready.
So do you change the angle of the loop? I've seen some people just...
No, not necessary. Not necessary.
Okay.
And what will happen is, when you are not activating the loop properly before cutting it, the loop will have a mechanical damage in the front and it gets obtuse. For that reason, you start doing the angulation which needs change. But if you have mastered the technique of engaging the tissue, first activating the loop and engaging the tissue, you will not be requiring it. You saw that I never needed to do anything to that loop because my mechanical push on the loop is very, very, very minimal. I've done anything. Everything is done by the energy. The loop stays intact. So what I'm trying, I'm looking at the tissue which is there. I take out the small tissues which is there in the loop, hanging down between the 11 o'clock and 1 o'clock. But in a bigger gland like this will be ended up in being resected because it will be quite obstructive otherwise. Sometimes they make a flap and create incontinence also. So incontinence because it blocks the sphincter area and coaptation doesn't happen. So I have almost done the evacuation, possibly another 1 minute. I'll finish up the evacuation part.
So sometimes you don't reach the roof. You have to really bend it. So what are your tips in
There's no other way. We end up in having an anterior commissurotomy in those cases. If it's a very bad way, I would say in my talk, the perineal urethrotomy is one way of doing it.
Okay.
But we can't help it because that is a tight penile ligament which holds the penis up, and we are not able to reach that area very well.
Yeah. Okay.
Right. This is a roof which is already taken away. There is some gland left, which I am taking it off. I'm taking it off.
Other thing I can suggest that you have to raise the height of the table then.
Yeah.
To reach onto the, on the 12 o'clock position.
Right. I think I have almost done my excavation. I'll come to the apex part, and that I'll demonstrate, and the evacuation of the fragments, etc., can be done by my colleague. I'll show the apex and go back. Come down.
And one comment I like to make, Dr. Mallikarjun, you are at the end, what you are calling it a toileting.
Sir, please, sir.
I think so. John Blandy has given a better term. That is, we call it shaving of the remaining tissue and all that. So you do a shaving of the remaining tissue.
Yes, sir. I learned.
You also achieve the hemostasis.
Yes, sir. That is the contention. It is an American word, sir. Toileting is an American word. John Blandy also described it as a shaving or a last shave, he said. And this is the excavation, what we are going to do. And that is the toileting and excavation both. I reached the capsule at majority of the places. And that is the main vessels on this side. I reached the capsule here. I reached the capsule at this area. And there is some bleeding somewhere.
So there's a question from your student, Dr. Prashant, about thicker loop versus thinner loops. To start with thick loop, and then once you reach the capsule, start using thinner loop.
No. That is basically for monopolar. Basically, what happens is the precision of a cut is good with a thinner loop. Actually, the thinner loop was devised basically or advised for bladder tumors because it will give a precise cut. So when the need to a precise cut without much of charring, you take a thinner loop. The same thing what happens if a monopolar instrument is there, as the time passes by, the central part of the instrument will become very, very thin, the loop, and the peripheral part of the loop will be thicker. So what you do, use the thinner part to cut and use the side part of the loop to do a coagulation. See this? That's how. Thinner part is not good for coagulation. So when you're looking at a coagulation as a measure, you need to use that thicker part of the loop which is there on the lateral aspect, or a thicker loop which is there. Thinner loops are not good for coagulation.
Okay, sir.
That's a point. I think I need to do a little more of excavation before I come to the apical part. Deepak sir, your goes, because I see you doing at 12 o'clock. I never shifted my hand. I kept my hand in the same direction and resecting.
Yeah.
Reversing the instrument and then doing it for a 12 o'clock. Am I right?
Yes.
How do you see? The only scare I have is by any chance if we move out without any problem for beginners. What's your opinion on that?
Look, orientation is the most important thing as far as prostate surgery is concerned. You must know where you are at any given point of time. There's no question. And orientation will depend upon the position of the verum and the bladder neck.
Yes, and I resist myself in keeping that way because I feel there is a very high chance of retracting backwards into the area of the sphincter. That's the reason why I defer and I train my candidates to do a resection by rotating it and keeping it in a neutral position than a reverse position of the resector scope.
No, I agree. I agree. That rotation is very, very good to detach a fragment or a piece instead of coming out into the pelvic floor area.
Right.
I'll make a comment when you come to the apex.
I'm coming to the apex, sir, now.
Yeah.
So I'm emptying and now I come to the apex. I leave some tissue on the left side which I can do a toileting. Okay.
Now you see there is a definite tissue, both lateral apexes.
Here I don't want to go. See my hand, left hand again coming here. I
Correct.
scoop the tissue behind that muscle.
Exactly. At the apex, instead of cutting into the mucosa, you can scoop the tissue.
Scoop the tissue behind that. This is what has to be done and learned properly. Majority of the times, people leave the tissue here. People will have some sort of an inadequate symptomatic relief because of this, of turn. So you don't need to withdraw the scope at all. Keep this and scoop the tissue behind the thing. I've reached the capsule here already significantly. Right. So from there, scoop the tissue again.
Yeah.
Scoop the tissue behind. So ultimately, I don't lose this muscle. See this? I don't lose this muscle. The gland is gone, the muscle remains. So that is the reason why the patients should not develop a stress incontinence. Idea is to not to lose that muscle. The same thing I do on the left side now.
Keeping the mucosa intact and scooping the apex is the trick.
Yes, sir. Okay. The same thing, I have done it on the right side and the same thing I do it on the left.
Now, if you were doing a ejaculation sparing surgery, you would preserve this area.
My left index, the little finger is showing where my pubis bone is, and I'm scooping the tissue behind the muscle. I'm scooping the tissue behind the muscle, and I'm scooping the tissue behind the muscle. I'm scooping it. If it doesn't scoop, I rotate it. If it doesn't cut, I rotate it so that I don't come. This is a rotation what I'm doing, so that I don't come beyond the area where I'm supposed to be. Rotate it. Rotate it. The tissue, rotate it rather than cutting it. Right, sir?
Yes,
I think that's what you wanted me to demonstrate. This is a part. Am I right, sir?
No, I just made a comment that if you were doing an ejaculation sparing, you would preserve this area.
Yes.
And not scoop it there.
Yes. I preserve an inch of this thing in front of the
centimeter of paracollicular tissue.
Yes.
Yeah. The centimeter is sufficient.
So I'll show at the end of this how it looks like now, what we've achieved by doing it. I have some more tissue here which I need to resect, but what I'm trying to achieve is retaining that amount of length of the smooth muscle under the mucosa.
Yes, yes. Very nicely demonstrated.
Thank you, sir. So don't move the resector scope, rotate, that's all. Rotate and excavate. Left hand is very, very important in doing this maneuvers. Left hand is very, very important in doing this. Rotate and excavate behind. Excavate, scoop, 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 scoop. That's it. I've reached the capsule here already.
You already seen
the capsule. Thin capsule I'm seeing already. I don't think I need to go beyond it at this point of time. Right. And now what I look at, right? There's some more small element of tissue here. which I take out, and you see how it looks like. You see that? That's a smooth muscle which is preserved in front of this length of the smooth muscle which is preserved. I can take out a little more tissue here, but I want to measure, I want to retain it. Your comment on that, sir? I think that is a crucial part of any TUR. What do you say?
Absolutely. Maintaining the apex intact mucosa is very, very important.
So the longer you maintain, the better the continence. So on the left side, on the right side, I maintain enough. There is some amount of overhanging tissue which I take out at this point of time and make it better. Is a
Since you are
little
using a
overhanging tissue.
bipolar, you can vaporize that as well.
I understand, sir, but I don't want to use too much of thermal energy. I try to understand. I'm against using a thermal energy in this area at all. Sometimes even if there is a bleeder, I don't even touch that, because that is the area, that's the reason why sometimes people have a loss of mucosa there. I don't want to even vaporize that area at all. The only reason why I take a mushroom is if I want to coagulate and there is a diffuse ooze, something like that, then only I take a mushroom. Otherwise, I don't.
Well, Karjo, the question was asked, Anil also asked you if the lateral lobe is going beyond the verumontanum, then how to resect them?
Same thing,
Or
sir.
you like to leave it there?
No. The same thing. You see, you need to resect it, but retain that muscle, retain that length, and then resect under the scooping around it. That's all. I don't think there's any difference what I do, whether it is, even if it is there behind, maintain as much length of the mucosa intact as possible.
So Viru is your landmark.
Veru are a little beyond Veru.
the
Sometimes
Malik, you had been doing this bipolar enucleation. So there you start from the apex. So how you rate this resection versus enucleation with bipolar?
of in enucleation, you will be able to take out more tissue than regular TUR in stopping it for some reason or other. But enucleation shows a removal of the tissue is much better in enucleation. There is no doubt about it. That's a proven fact about it. But what happens is whenever you have a gland which is enlarged beyond the verumontanum, what will happen? The whole muscle will be getting compressed towards that towards the floor. So losing even 2-3 millimeters
So Malik, you are an expert resectionist. You are showing it very well. But the question from the beginners is that when do you call it adequacy of resection has been done and you don't want to proceed further?
Why everybody's suddenly so quiet?
Yeah. I don't know whether you could hear me or not. I was asking that adequacy of resection, what are the factors that you are able to decide that now we have achieved complete resection?
Connected?
Malik,
Yeah. Yeah, transiently, I think you lost your signal.
Okay. So can you hear us now?
hello.
Sir,
Hello.
This audio, there's no audio at the moment.
Are we back?
Yeah,
can
now
hear-
we can hear you, Malik.
Endo?
Yes, we
Endo
can
is
see the endo.
visible.
Okay. I think there was a transient net disturbance. I think I finished my resection. I'll show you
Yeah,
once
so
I
the question
evacuate.
asked was, Malik, adequacy of resection, the criteria to define adequacy of resection.
Number one, safety. That is number one. So look at your safety. Number two, you should be able to see all the capsular fibers on all sides. I should not.
Malik, if suppose you were to do enucleation on the same patient, can you hear me? Audio. Hello.
Yeah, are we audible?
Well,
Malik?
I can hear you. I can hear you.
Yeah, I can hear you also, sir.
Yeah, but then maybe
But
Malik is not able to hear us.
yeah,
And intermittently he keeps on we keep getting his voice.
Am I? Are you able to
yeah,
get me?
we
Now
get
I
your
can.
voice intermittently, Malik.
Oh, no, no, no. That was a. I think everything is fine here. Let me. I think just check it once. Huh? I think now it's stable.
Now endovision has gone. We would like to see the fossa 360 degrees
Yes, sir.
from
I'll show
below.
you. I'll show you now. I'm just doing a toileting part. Endo has come.
Endo has come.
Endo has come now.
So this is how it looks at the end of a thing. See this?
Yes.
Yeah, apex is nicely seen.
Then the mucosa and the smooth muscle is well preserved, and this is a mucosa, and there are some small areas of small tissue which is there, which I'll take care. I don't need to bother about it. I'll just make a proper evacuation of the fragments, expect that there's no fragments inside, and then look into it.
Malik, if you were supposed to do a enucleation on this same patient, would have taken you more time?
Of course.
Enucleation would have.
Of course. You see, enucleation time is going to be the same whether I do a smaller gland or a bigger gland. It doesn't make, because the movement, everything is going to be the same if I do a smaller gland or a bigger gland. Whereas resection, if I do a bigger gland, the time is going to be go on increasing. In a smaller gland, suppose that's the reason why If I need to do a enucleation, there should be advantage when I do it for a bigger gland, not for a small gland.
Yeah, if you look at the enucleation efficiency, it is more with larger glands.
Yes, of course.
You can go up to 2 to 3 grams a minute. Here you are averaging 1 or nearly 1 gram a minute. So for optimal 60-gram prostate, I think this balance is out.
So resection is better for 60 gram, according to you. Anil?
No, I always favor enucleation because you are completely enucleating all around. Here you are, because Malik is an expert, but if you have a beginner, you will always be unsure that have you done adequate resection. And many a times the bleeding overrides. As Malik said, that safety is the issue. So if you are favoring safety, then obviously you will have to leave at some stage, which may not be complete.
So there's a very thin line between complete resection and adequate resection.
Yeah, very true.
And it will vary from patient to patient, depending upon so many factors related to patient, factors related to surgeon, factors related to actual happening things on the table.
So that is why the enucleation procedures have come into vogue.
See, can I interrupt now?
Sir, please, sir.
Yeah, no. What Anil, you are saying, same is the problem with the beginners when they are doing HOLEP. It is not that simple procedure to be learned actually. It has to be learned properly. You are expert, you can do whatsoever you want to do. So question is, TURP is the basic. I think so every resident, every urologist should learn first the TURP. Then they can change over to the HOLEP, and later on in their practice, whatsoever they want, they can do it. That's a different matter, depending upon your situation, where you are working, availability of the equipment, availability of the laser machine and all that. So I think so for postgraduates who are under training, TURP is the must. They should learn actually, and then they can extend to any other procedure they want.
Yeah, I think I fully agree with you. TURP is a must-learn procedures, but when we have complex BPH, then definitely we have to.
Sir, at the end.
Yeah.
At the end, I think I finished my resection. At the end, I always look for the ureteric orifices. I have not done any damage to the ureteric orifices. Second thing is always say, just below the bladder mucosa, are there any veins which are bleeding? Just look at them. That's the second step. That's the second step, because these are the vesical varices which tend to go inside and you will not be seeing in the prostatic fossa. So those are the things which need to be taken care of as you are finishing the job. And third thing is going to be a bladder neck and a prostatic junction. This is the vesicoprostatic junction. This vesicoprostatic junction is the area where all the bleeders enter into the prostate and the major vessels enter into the prostate. So look at that area. These major vessels will come only in this area. The rest of the prostatic, these things, we really don't bother. If you are able to take care of these things properly, this is the main vessel. You saw that this is a coagulated main vessel under the fat. And if you have taken care of this, I don't think there is anything need to be bothered about. So this is the end appearance of it. Sometimes you see a small flap of the tissue there. What is your opinion? I don't resist.
Just leave it.
Leave it. Get stuck. You see, this sort of a flap. This sort of a flap happens even in HOLEP also. We tend to create that
this
flap.
is best left alone.
Left alone. It gets stuck.
Actually,
Yes, it gets stuck into the anterior part and it doesn't bother it. Longer flaps need to be taken care of. Shorter flaps. I've stopped the irrigation also. I don't see much, and I'm taking out my scope, looking at the urethra. Have I done anything done to the urethra? Nothing, and it is okay. The urine color is okay, acceptable. Catheter, please. Can we go to the next presentation, please?
Yeah. Coming to that discussion of adequate resection and extended resection and all that, I think so. Surgical capsule is there, and superficial surgical capsule, that is a landmark where we have to stop. Whether you are doing HOLEP or you are doing bipolar TURP, a good resectionist knows and what Mallikarjun has very nicely shown. Most of the places capsule is there. A lot of studies have been done. How much tissue is left behind? So average is around 30% tissue is left behind. A lot of studies have been done. I'm not quoting different series. So we have to explain to the patient also that we are leaving the peripheral zone intact. We are not taking out the peripheral zone. We are going only up to the surgical capsule. We are taking out the adenoma only. We are not resecting the complete prostate. So that has to be the message. Should we counsel the patient accordingly? Otherwise, later on when ultrasound is done, they will say, "Oh, my prostate is there."
Most of the radiologists report as TUR defect, and they keep on asking me, why have you created a defect? So mentioning it correctly is important. Patient must understand that. Are you trying to show us the clips of iTIND?
Dr. Ajay Sharma is asking, we had bladder neck incision in almost all cases at the end. What is your opinion, Malik, about it? Or Dr. Deepak?
Well, the way Malik showed the bladder neck wide open, there is no need for incision.
No need.
Only if you find that having resected adequately, you still need to look down to the trigone. Yes, that's the point where I would like to make a bladder neck incision at 5 and 7 to flatten it. But the way they look like, there's no need for a bladder neck incision.
There is another question from a colleague that is it better to leave little bit of prostate rather than doing aggressive resection?
It will all depend upon the age and the comorbidities of the patient. For example, if I'm doing a 92-year-old person with comorbidities who is in retention, I don't think I'm going to go down to see capsule everywhere else. I would create an adequate resection, an adequate fossa for him, and he should be fine. So it will depend upon the patient.
I think the message should be very clear that it has to be as per the need and as per the comorbidity status of the patients.
And what's the need of the patient, actually.
Yeah. In this case, Malik, will you give any traction? I think he has left for another case. There is another case of iTIND.
No, I think
The pre and post iTIND placement and removal cystoscopy videos. So it's a 57-year-old male with hypertension and obstructive LUTs since 2 years. He has a 30 cc prostate and he had a QMX of 10 ml per second. So iTIND was planned, and this is the pre-iTIND cystoscopy. We see a grade 1 lateral lobes and a small bladder neck elevation as well. So this is post removal. We can see the grooves at the 5 and 7 o'clock position, and as well as the 12 o'clock anterior groove. This patient had post-operative LUTs, which was managed conservatively. He is voiding well right now. So we'll go to the next case presentation.
Can you hear us?
Hello?
So this is a 49-year-old male who is hypertensive and having obstructive LUTs on alpha blocker as well. On rectal examination is a grade 2 prostate, and ultrasound is suggestive of a 38 cc prostate with a transverse diameter on truss of 5.1 centimeters. His QMax is 10 ml per second. This is the transrectal image and uroflow. So he is planned for UROLIFT.
Hello?
Hello?
Hello? Deepak sir?
Yes.
Okay, that the question is, we'll put that for that patient, I didn't put any traction. I'll just observe if necessary, as Dr. Gupta was talking about. We'll put a very mild traction onto this so that the fossa blood will not go into the bladder.
Okay.
So this is the next case which has been presented, and a young man, you have the data, and he didn't want, he selected UROLIFT as this thing because he wanted immediate relief. He doesn't want to have a catheter. He doesn't want Rezum for a catheter for a longer period of time. And he wanted UROLIFT as an option for him when it's been explained. This is a cystoscopic picture which shows grade 1 or grade 1 lobes only, little lobes here and a little closed bladder neck. That's all. And that's a bladder neck area with a little amount of bullous edema, probably previous infection or something. So I don't think I need to put too many clips, possibly one on this side and one on this side should be. What I do at the starting of the procedure is I see the length of the prostatic urethra. Now I've kept it at the bladder neck. Now it is this way. And how much is the length of it? Is I come out to the Veruma. Prostate, the size of the prostate, the transfer dimension of the prostate. Because whenever there is a UROLIFT, the needle goes beyond, is around 3.3 centimeters, and the arch is around 1.5 centimeters high. So if at all, if I need to put a UROLIFT, my scope should recede by 1.5 centimeters here, just above in front of the verumontanum, it will become, because 1.5 centimeters here, and then push that needle. So the second point is the needle goes beyond 3 centimeters. So if you have a transverse diameter of 8 centimeter prostate, UROLIFT is not going to be of any use, because the needle cannot go beyond the capsule of the prostate. So anything which is around 6 centimeters, 6.5 to 7 centimeters, where we give a little pressure onto the prostate, the needle can go across, but beyond that, it cannot go across. You got my point, sir?
Yes.
Yes, yes.
And the second point is going to be, we are going to create a channel in the roof of the prostatic urethra, not in the base of the prostatic urethra. We see majority of the time.
The base doesn't look obstructed at all.
No, this is obstructed.
No, the base.
Okay, you got it? Hello?
Hello.
Yes.
No. This is a special cystoscope with a longer bridge. You see the bridge? It's a longer and a longer telescope. This is especially only for UROLIFT. So you need to purchase this and keep it. So I've taken it out. I'll take a UROLIFT, and this is the UROLIFT procedure. This is a gun, UROLIFT gun. This is to lock with the cystoscope, and this is to unlock. First button. Second button, this blue button, is to fire, and then bring it completely, and thread will come out, the clip will come out, and the last button is to cut the thread after clipping it. So 4 steps of it: unlocking it, first pressure on this side, second pressure, and the third device, the string being clipped and cut it away. So let me look. How does it look like? So that's a telescope which is being done. So the device is going through the cystoscope, which is around 20 size. The device is inside. Okay. That's a position.
What degree telescope is this?
This is 0 degree telescope, sir. I think 0. So the saline is on. So this is the verumontanum. Table down, please. This is the verumontanum. This is the place I need to come 1.5 centimeter in front of it. before, rotate it, go to an area in the roof. Between at this level, 1.5 centimeters away from it. Otherwise, what will happen? The thread will go through the bladder. So I'm going to unlock it, fire it, tighten the thread, and just move a little forward. You see a white line coming up, inside the thread.
Yes, we can see that.
Right? And then we clip it. Right? There is a... Okay, come back. I'll show you. Come down. Let me see, assess it once. Yes, come back. That's it. Oh, it's a little near to the bladder neck. The pressure, and I'll take this side on this side first. I go into the bladder and see is there any bleed.
Malik, if you do see it in the bladder, how difficult it is to take it out. Hello?
I'll come back. I'll shift it to my right hand. To my left hand. Yes. Come back. Yes. Shift to the left. No, it's near. Yes, here. And then unlock. Press. And then move a little front. You see that white line coming up? Yes? Yes. Fire it. So having done two, I'll just see how the thing look like anteriorly and then decide what next to be done.
Malik?
Yes, sir.
If the firing is not as per your requirement or as per you think it should be, how difficult it is to replace it?
You're in trouble, sir.
Okay.
As far as possible, you're in trouble. That's it, exactly what I'm saying. So I may think about one more here. I'll just see. This is a Veru. This is the area. This is a small opening up which is created. I may think about one more here and then decide. Give me one more.
Yeah, you need one more.
Take the one more. Okay, come back from here to 1.5 centimeter. That's a Verumontanum. I rotated it and I came a little above the Veru. That's the area where I was supposed to unlock. Move a little front. Yes, I see that white line. Fire it. Clip. Second clip might not be needed on this side. So we are all looking at the roof part of it. We are not looking at the bottom. We are looking at the roof. This compression-like thing will be there. I'll decide whether I need to take one more here now to get that opening up. Can we get one more?
I think.
Yeah.
I think
One
yes.
more. One more.
You can apply one more on right side.
You see, the thing which looked as if I need only 2 clips is ended up in having 4 clips, which I don't. This is what happens in UROLIFT. We cannot predict this, and this very problem with this, how many clips we'll be using, we'll not be able to guarantee and tell them beforehand. Because after each clip, the whole appearance might change. That's a problem with UROLIFT.
What
So,
is your experience of median lobe?
Median lobe, I don't do, sir. Simple. I don't do. That's all. So this is the Veru, and just in front of the Veru, and I'm pressing it on this side, unlocked.
Your image is frozen.
Wait,
Endovision is frozen at the moment.
is it? One minute.
Audio gone and endovision also not working. Malik, can you hear us? Hello?
Audio visual gone.
Sir, just wait a minute, few minutes, sir. There's some problem, technical problem. We'll get back in 2 minutes. Yeah. వచ్చింది. So just move it, sir. We are there. Got it. Yeah. Yes.
Yes, now
we got it.
Now, yes.
So what I'm trying to do, this is in front of the Veru. I rotate it. I know where I am there, and that is the area where I wanted to fire. I unlocked it, fired it, compressing the thread, moving ahead, seeing the white line, and then cut it off. That's it. Come down. I think this 4 should be good enough or more than enough. I don't think we need anything more. I think it's overdoing it. Okay, if I come back, I think that is the channel what we created in the top. This is how it looks like mostly. And though it is not impressive, but it will definitely have some sort of a symptomatic relief for them.
And what's your longest follow-up on this?
I'll definitely, of course. Catheter, 14.
Malik, what is the follow-up on this? UROLIFT?
And then we will do I don't think I need to put them on any alpha blocker. Tomorrow, probably we'll do a uroflowmetry after 2 weeks and see. Possibly, if at all I keep an alpha blocker, I keep it only for a week and then stop it.
Malik, any difference in patients who were on dutasteride for 2-3 years and the application of the clip? Does it differ? Patients who are not on dutasteride and who are on dutasteride for 2-3 years.
Patients will not be on dutasteride. So they're all young fellows retaining ejaculation, etc. Most of these patients are not on dutasteride. I don't think there is a much difference in any of those things. The only thing what we need to look into is 2 aspects. Number 1, the thing should not go into the bladder. Number 2, see, there is one more problem that can happen. If you go between 10 and 2, before that, there is one is GVC, another thing is bone hitting. It may hit the pubic ramus. If the thing goes beyond 3 centimeters, it hit the pubic ramus, and dislodging it from the bladder, from the ramus is very difficult. This is one of the very difficult problems which happens during UROLIFT, hitting the pubic ramus. It hits the pubic ramus and doesn't dislodge from the pubic ramus. The needle doesn't dislodge. So we should be very careful whenever you're doing it with pubic, it's called bone hit. So that's one of the disadvantages. So never go between 10 and 2, retain underneath it, never come below 9 and 3. So 3 and 2 and 9 and 10 position is an idealistic way where the UROLIFT has to go. And that will give you the opening into the roof.
Any experience resecting a patient with a UROLIFT?
Yeah, it is. I don't think that's a problem. The only problem it happens is this clip, what is there on the surface, will get incorporated into the prostate over a period of time. So your loop may get damaged because of the metal coming up in a resection, but the nitronol wire doesn't get any problem at all. It doesn't cause any problem.
It's the bipolar which can give bipolar gives trouble.
Trouble.
You need to do it. You have to use a unipolar to resect the prostate.
It's a very temporary issue there, very temporary, and once that loop comes out, everything is all right.
Dr. Deepak, it's a laser which is very good for these failed UROLIFTs. I have done, and with enucleation, you can cut the loop at the capsular level and it comes out easily.
Yeah, I think laser would be a perfect choice for this.
Most optimal.
Next case can be present.
Hello? Sir, next case is Rezum. This case. This is a 66-year gentleman with comorbidities of diabetes and CAD, post-CA, stopped antiplatelets since yesterday, obstructed legs on alpha blockers, clinically grade 1 prostate. USG is 30 grams of transverse diameter 49 mm. Is 52 mm.
Again, the voice has gone. Some problem with the voice. Audio. Kindly check.
Proxy of 30 cc gland, transfer diameter 49 mm.
So are we connected, Malik? For some time we have silence once again.
Hello?
Yes.
Are you audible? Am I audible?
Yes, you are audible now.
Right. Well, this is a patient for Rezum. We are taking a patient who was already on post-PTCA, you would have heard, on multiple anticoagulants, and then significant obstructive voiding symptoms, not responding to alpha blockers. This is the gland what you are seeing. It's not a very big gland, but this is a procedure what we are planning for him today, because I can start off the anticoagulation tomorrow morning itself. So there's a small median part, and there are two small lateral parts of it, lateral lobes of it, and the rest of the bladder is quite normal.
When did you stop anticoagulation?
3 days ago, sir.
Oh.
So, Mallikarjun, what about UROLIFT? Why in UROLIFT you think bleeding is there?
Audio gone again,
Audio
Mallikarjun.
gone again.
We can't hear you.
Malik? Malik, can you hear us?
Is it from backside or our side?
Yeah.
We can hear you now.
Yeah, I got it. So picture,
The question
external
is,
picture.
Can you hear? The question is basically,
Sir.
you have shown a iTIND, you've shown a UROLIFT, and now you're talking about a Rezum. Why Rezum
Yes,
for
sir.
this particular patient?
No, you see, the choices, see, there are options which are given to the patient. This patient, I would say either UROLIFT or Rezum. Both of the things are going to be good for him.
Okay.
See, there is a lot of patient choices which are creeping into picture now. So that is the reason why, in fact, this patient I offered both UROLIFT or Rezum, both of the things I said. So he said he has heard about water vapor therapy and he knew about water vapor therapy. He doesn't want to have a foreign body inside. So some reasons they'll tell and they say that they want a Rezum for this patient. And he said, I don't mind having a catheter for a week or 10 days duration, not a problem at all.
So it is more of a patient choice than
Yeah,
the
of course, sir.
choice.
Yes, sir. The only some areas like a bladder neck obstruction like thing, like a patient who had a 40-year-old with a high riding bladder neck, where I can't think about a UROLIFT or a Rezum. But rest of the cases, things are options are open for them.
Okay.
Mallikarjun, can I ask you one thing? You have all the modalities in your center. So have you purchased all these machines, or you think every time a company person is coming to you? Like in today's demonstration, your company persons are helping, or you are doing of your own?
No, sir. No company person is there. UROLIFT, you don't need anything. UROLIFT, you need to buy I have already bought those cystoscope and all. iTIND, you don't need to buy any capex. There is no instrumentation which need to be bought. Rezum is our own. We've been doing it past 2 years. Rezum is our own. We've been doing it past 2 years. So I don't think we need. There's no company person at all today.
Okay. No,
so we are doing this procedure very regularly, sir.
No, in your center, your volume is high, so you can afford to have all these things. But think of a small single urologist nursing home. What he will do? He has to get a company fellow every time.
Yeah, but the Rezum is available on rent.
Yeah, that's why I'm saying. In my place, I'm getting company fellow coming every time.
Rezum is the only thing what is necessary as a capital expenditure. Rest all don't have a capital expenditure at all.
Does it make any difference in the cost of the treatment? If you have your own
well, they're almost the same, sir. I think everything will come the same.
Okay.
So, like coming to the Rezum procedure per se, we are looking at we have 2-3 things which we need to look at. This is a Rezum gun, we Rezum element which is there, and now I am just priming the gun. This is a telescope, and this is a 17-French sheath which is going to be there. And there's a telescope. Its torch can be used. Torch can integrate itself very well. So there are 3 aspects of it. Number one, this is for pushing the needle inside. This is a pushing for needle inside. Switch it on. That's the needle which is coming on. And the second thing is going to be water vapor injection. This is called priming. This is called priming. We say that this is called priming. So the priming involves passing the saline coming up into the instrumentation. The saline is coming up here. So that's what is happening. The needle into it here. Get back by pressing this button, the needle will go back. Now the next step is going to be checking the vapor to form. This is a needle with multiple holes. The water vapor is going to be generated around it. Pre-treatment vapor cycle it is called. Pre-treatment vapor cycle. Done. So the gun is ready to use. If you see the treatment log, you will have you will have 0, 0 now. So every use, it will become 1. And a 9-second cycle, it is a 9-second cycle. And this gun the gun can be for 15 uses. Sometimes we reused it, wherein we finish it around 7 or 8 uses. This case may not require many, probably 2 or 3. Suppose the rest of the uses, we again sterilize it, dipping it, and then sterilizing it, using it. But every re-vaporization will lead to cycle will lead to loss of 1 more use. So you may end up in having 12 or 13 uses at the end of the day. So this is by pressing it, you are creating a water vapor to come. There is a turbo flow also. By pressing it twice, it will be coming up inside. So I am passing my scope inside.
End of view, we need a yes.
Low, but there is a tissue here. So what is a vapor cycle? Vapor cycle is going to be around, the vapor is going to be creating a 1 centimeter water vapor cycle with a 0.4 ml of water. So the water, so it should be minimum of 5 millimeter away from the bladder neck area and 5 millimeter away from the sphincter. That is at the level of Veru or 5 millimeter below the level of bladder neck is a way where you can inject. Avoid injecting at 12 o'clock or 11 o'clock because if the prostate is very thin, you will be entering or vaporizing the dorsal venous plexus. So that's the reason why avoid that area. In this area, my planning is there is some amount of tissue in the bladder neck area. So I gum this 5 millimeter away, which is the length of that what you see in front of you, and then push this and start creating a vapor cycle. So you always move from the proximal to the distal area. I'm creating a cycle there. So 9 seconds, it is over. Get the needle back. Get the needle back. Idea is not to create blanching of the mucosa. The idea is to create.
Audio has gone again. We can't hear you, Malik.
Malik, we have the endovision, but we can't hear you.
So you can talk.
Hello?
Yeah. Hello?
Yes, we can hear you now.
Okay. So, so I injected 1.
It ends up in having a blanching into that. Okay. Old one, huh? Okay. Okay. You got the thing. Second one is done. Hello?
Yes.
Yes, yes, we are
Yeah,
listening.
yeah. So this is the explaining.
How far away from Viru you are injecting?
I can level of Veru, sir. I can inject at the level of Veru. I injected one here, and then I'll come a little lower down, just below the Veru, just at the level of Veru, and inject one here. Because it goes around 5 millimeter. So at the level of Veru also you inject. The smooth muscle, the sphincter is going to be a little few millimeters away from it, so it is still possible. That's it. 2 injections are over on the left lobe, and possibly the same thing I'll repeat on the other side. This is a half. This is a air bubbles are problem.
In UROLIFT, it was 11 and 1, and now it is nearly 5 and 7.
Which one?
The injection, the UROLIFT, you had clips at 11 and 1.
No. Between 9 and 10 and 2 and 3.
Yeah, and now your injections are towards 4, 5, or 6.
No,
4
I
or
don't
5.
want to go to the floor. I don't want to go. That's all. I come 5 millimeters away from the bladder neck area, and I don't want to go into the floor or the roof. Either of the two areas, both areas.
So my question is, the direction in UROLIFT and direction in Rezum, both are different. Does it affect the outcome?
No, it's almost the same. I don't know why you are saying different. It is same.
No, Mallikarjun, what he's
Sir.
what he's saying is that in UROLIFT you are firing between 2 and 3 and 9 and 10. Here you are firing at between 4 and 5 and 7 and 8.
No, this is also lateral.
Sir, this is also
Both are
lateral, but this is multiple. This is not one, right? This is multiple. This I say I've done it here. I've done it here. I done it one here, and I did it one here and one here. I've made 5 injections in this patient today. So for this size of the prostate, 5 injections is good enough. What I wanted to tell is you need to select in those areas. I don't want to inject between 10 and 2 because the prostate is thin and there is a DVC above. And I don't want to inject into the floor because this is not the area where the obstruction is there, so you don't inject. So inject into this lobe, inject into the lobe on either side, but you inject the areas where the projection is there. That's how you're going to inject. That's all. I don't think there's any big difference between the two. In UROLIFT, you don't try to create a...
Again, audio has gone.
Launching of it, which is not there. Point the audio.
Yeah, you're back.
So complete blanching of it, which is not correct. Hello?
Oh.
Yes, we are listening.
Got it? So this is you should have the vascularity onto the mucosa, and you should have occasionally, if it is very superficial, you may have blanching, but avoid blanching of the mucosa. That produces lot of hematuria in the postoperative period. So I've given 5 injections. I don't think I need to do anything beyond. I just take it out in this now.
How long you like to leave a caster in Rezum?
I leave a catheter for a week's duration.
2 weeks.
1 week duration.
1 week. Because patient may have lot of dysuria when we remove the caster.
Lot of dysuria. No, this is, sir. One thing which I always say, the patients who are selected for any missed procedure should have a normal bladder. The problems of miss is always because bladder was bad. Your energy sources have done a great job, but when the bladder is not good, the patients will not be happy, and the patient.
The voice is going again.
Yeah, after most of the time, then if I, most of the time, what I see is the patients have taken out, the catheter is taken out on the 7th day. We always look for a post-void residue. Patients may not be able to pass in 20% of the times. We may need a catheter again for 10 days more, 10 more days, and then we take out a catheter. People may have a relief of the symptoms by the end of 1 month, but during this time, their ability to empty the bladder properly is not going to be great. In some diabetics with this long-term catheterization, there is a lot of colonization of bacteria. And the only problem, what I started seeing in Rezum is that 20% of the patients come with recurrent UTI in the postoperative period. That is the problem in these patients. So rest of the patients, it's fine. Rest of the patients, especially younger fellows, 55-year-old guys with a 45-50 grams prostate with a normal bladder, they do extremely well after Rezum. After 10-15 days, they do pass urine well, but at the end of 1 month, their ability to pass urine is going to be extremely good.
Malik, I had to deroof for prosthetic abscess following a Rezum. What's your take on that?
Well, I haven't seen it. The 2 occasions where I had a it has come. 2 occasions where I had a prosthetic artery embolization. I haven't seen a patient Rezum coming with a prosthetic abscess.
There's a question from Dr. Sharma from Gangaram Hospital, Delhi. Out of the 3 missed procedures, which one gives the most satisfactory result for the patient and the surgeon both?
Surgeon, there is no orgasmic feeling of any of the missed procedures. That is one thing is shown. I think all of them have got the role in their respective fields, respective scenarios, clinical scenarios. But the best result happens only when the bladder is normal.
And Malik, we have a lot of
when you say normal, what do you mean by normal? Means you should do a urodynamic to check or what?
No, sir, I don't need to do urodynamics. What I'm saying is, suppose a long-standing diabetes, 10-year-old diabetic patient, you are looking at an outlet flow, low flow rates, and you're thinking the Rezum gives the best possible result. It may not. It may not give you the best possible result.
What about irritative symptoms? Patients who are having irritative symptoms, should we do that, these missed or not?
I don't do that. That's exactly what I'm saying. If there is a detrusor dysfunction, high post-void risk.
Voice gone again.
Voice is gone. Today something is wrong with your audio visual. You have to fire it. Anand, we are remembering Anand.
Now it will be there, I think. No, there's something wrong here. Never it happened before. I don't know why. We have a 500 Mbps Wi-Fi. It is getting down and down all the time. So whenever we see a detrusor dysfunction, like lot of post-void residue, etc., we let us not do any of these missed procedures. They are not going to be indicated in these cases. So you should be sure a high pressure voiding, high pressure bladder outlet obstruction is the ideal place where mist is going to be helpful. Yes. Next case. Next case ready. We'll present the next case, sir.
So Malik, in small prostates, most of them are infected, have chronic prostatitis, fibrous glands. How does it work?
Can you
This case is a 79 years male who is diabetes, post total knee replacement 2 months back, failed trial without catheter, clinically grade 3 prostate, USG of 82 cc with obstruction. The plan is HOLEP.
Malik?
So they're calling you.
Hello?
Yes.
Yes.
Sir.
No, I wanted to know what is the costing for these procedures in your hospital?
Sir, everything, the iTIND may cost around 2.5 lakhs. and the UROLIFT, depending upon the number of
clips.
number of clips. Rezum costs around say 3 lakhs of rupees. That's all, sir. Sometimes we consider this way, that way. Sometimes we may do it of a Rezum and a 2.5 lakhs also, depending upon the usage what we do.
Okay. Good to know.
So the next case is going to be, I've heard it, it's a large prostate for a HOLEP, sir. Dr. Taif is doing. You can communicate with Dr. Taif, sir.
All right. We have a wonderful endovision at the moment.
I'm audible, sir? Yeah, good morning, sir.
Very good morning, Taif.
Sir, at the outset, I would like to thank for having me this opportunity. So I will be demonstrating the HOLEP procedure for this 80cc gland. So this is the endoscopic view. It's a trilobar prostate. The left side groove is well maintained. Right side, it is fused to the right lateral lobe. So it's a good gland actually to demonstrate either a trilobar, bilobar, or en bloc. So instead of a trilobar, I would demonstrate here a bilobar one because since the focus has been on the beginners and the learners. So in trilobar, you would have made an incision at 7, 5, made the grooves and disconnected from here. So in bilobar technique, we would make a groove at 5 and then at the roof and disconnect from the distal mucosa. So we will be starting off now. This is the landmarks. This is the sphincter zone. And like we were discussing about the hello.
What is your take on en bloc enucleation?
Yes, sir. Absolutely possible in this case, sir. Said to be slightly faster. Initially quoted to have a better continence rate, but somehow recent studies have not shown that significant changes. So which proves the point that incontinence post-HOLEP is not a single factor entity. Multiple factors are there. So only the technique will not be the thing. So even a bilobar or trilobar technique, if done adequately well, properly, so the continence rates would be the same. So these are the landmarks, bladder neck. This is the orifice. And the most important thing, this is the zone of the sphincter. And luckily, this gland has not projected too much beyond the veru. So our safe zone would be to preserve at least this amount of mucosa and the functional sphincter lamp. So the first step would be making an inverted U incision. This would be the easiest way to start off and find the plane, because here the adenoma and the capsule are close by, and our target would be this white line of Hilton. Okay, so the settings here would be anywhere between 1.5 to 2. So slight traction onto this and incising the mucosa.
Which equipment you are using?
I'm using the Quanta laser, sir, and the element is from Olympus. This is a conventional one with 26 sheath.
What are the energy settings?
Energy settings, it is 1.8 joule and 45 hertz. So if there is a option for modulation of the pulse width, that is even better. Here in this, it is not feasible. So if it is there, then we can adjust with a short pulse width for the cutting effect and a longer pulse width for coagulatory effect. So we have identified this plane here between the adenoma and the capsule, and we create it, identify it. So once the bleeder is there, we can either defocus and coagulate or go for a setting with the other pedal with a lesser energy. So
most of the beginners, they find difficulty in getting into this plane. So what are your tips to get into this plane?
Yes, sir. The easiest site to identify the plane is just beside the veru. Here the plane is most easily identifiable, no much of tissue there. And slight gentle traction after incising the mucosa should get us the plane. So we have to look for the plane, and the landmarks are these arbrizing vessels and corpora amylacia. And once you can see that, it opens up. Okay, so I would make a similar incision on the left side. I haven't been able to identify the plane yet on the left side.
To identify the plane, what will you do?
Slight gentle traction and push on the adenoma. It
Yeah,
tends to open up. Not too much of
that's the trick. Yeah. So that balancing the force is very crucial here. Because if you put more force, you can go outside. But if you have less force, you may not be. Now you are getting into the correct plane.
Yes.
So the bottom line is that apex, you must get into the correct plane in the beginning itself.
So I might be slightly deeper here, I guess.
Yeah. So you have to be careful.
Yeah.
And that is known as course correction. So course correction means if you see some stretching of the capsular fibers, you leave that area and come from the side.
Just join the two and complete the inverted U incision here.
What is your take on keeping the fiber at 6 o'clock or let it come from 12 o'clock?
The dissection near closer to the bladder neck, there's a lot of advice to get it away from the 12 o'clock with the reverse thing. I think if you are sure about where the firing of the laser is happening, it would not make much of a difference. So if it is helping out in giving a counter traction to the adenoma, that is well enough. But otherwise, would not be making much difference, I feel. So just creating this 5 o'clock groove
5
here.
o'clock groove you are creating now.
Yeah. So if there is no median lobe, we can make this groove at the 6 o'clock.
The question asked always is that how you prevent undermining when you are dissecting at this area, mid fossa.
Yeah, slightly remaining on the safer side. The biggest landmark is the fibers of the bladder neck. There's always the risk of undermining here. So we have to be very careful, especially at this point here now. So this is the area where we might undermine. So initially creating the inverted U incision and lifting of the adenoma to some extent gives us an idea of the depth of the adenoma. So instead of blindly searching for the depth upfront, if we are making the groove as the first. But yes, searching for the landmarks continuously, the arborizing vessels and the capsular fibers should help us prevent that. Increasing the width of the groove at 5 o'clock.
Any tips to the youngsters to prevent this injury to ureteric orifice if they are very close to bladder neck?
If it is very close, it is always better to come from lateral side once the dissection is done. While making this incision, make sure you are doubly sure as to where the incision is extending onto. So there is no substitute for repeated cross-checking. I've lifted the right lobe and the median lobes to some extent here.
Widening of this groove, this helps a lot because now what you are doing is you have created a groove.
I'm widening it.
Keep on widening it. That would give a good irrigation dynamics as well as opening the channel, and that would help.
So once this is done, I would proceed ahead with the circumferential incision of the mucosa at the apex. So this is the veru, the corresponding site at the roof, going slightly ahead inside, and this would be our mark for the roof. So I can incise from here till here to create the groove at the roof. So and then connect the groove which we started here at the 7 o'clock. Okay, so I'm connecting this mucosal incision here.
I think this is an important step which must be highlighted,
Yes,
that this mucosal incision must be given not in the beginning, but at some stage when you have both the ends seen beautifully. Because if you give it in the beginning, you may not always be able to reach to the lateral limit.
Yes,
But
sir.
once you have dissected the floor, then you can definitely give this incision nicely. Look, this thing, preventing any injury to the sphincteric pillar.
I'm just deepening the incision.
Another important thing is that the enucleation here is all retrograde. So the difference between a TURP versus laser, that in TURP you always side the neck and come towards mid fossa, and then at the end you do apex. Here it is reverse. Reverse means you are at the apex first, and then you are doing retrograde enucleation all throughout.
Yeah, the most important step comes up very early in HOLEP.
Yeah.
And this release of the mucosa and the apex is the most crucial step. So partly I've marked up here. I'll do the same thing for the left lobe so that the apex is released early, the early apical release. Now we can incise it completely and join it here, or like as you highlight, we can leave a strip of mucosa also here and make it at slightly say 1 o'clock. So I'm just marking here. Initially, maybe we can use low energy settings at the mucosa so that there is no oozing. Often, if the same setting of cutting is used, the oozing here will prevent exact dissection. And since the space and flow is not adequate yet here because of lack of space creation, so we might lose vision and compromise our landmarks. Okay. So just marking.
This machine, I think, must be having both the foot pedals.
Yes, we have both the cutting and the coagulation, so I can intermittently change it.
Yeah. So what I do is that for giving these marks, we come to the coagulating foot pedal, and for the other we come to the cutting foot pedal.
Cut, yes, sir. Yes, sir.
So if you can mix, you judiciously balance out the two things, that would be wonderful.
Yes, sir. So incising the mucosa on the apex on the left side. As we go anteriorly, my incision is moving more proximal towards the bladder neck so that we have adequate length of the mucosa.
The vision is not very good.
Sir.
Vision is not very good. Yeah.
Now better, sir?
Now better, yeah.
Okay.
Now better.
So now at this point, like I said, we have the option of making the grooves at the roof. And either leave the strip or divide it off.
So you have left a lot of mucosa anteriorly. That means from 11 to 1. Is that true?
I have gone slightly more proximally, sir. That's all. So just widening the groove at the roof.
Anil, I like to clarify this point, whether you should start at 12 o'clock or you want to leave a strip of mucosa between 11 and 1.
No, sir, that is dependent on the size of prostate you are dealing with. If you have a small prostate, it is always good to leave this in between 11 to 1.
No,
But
that
if
is
you
one,
have
but this is a large prostate. This is not a small prostate.
So if you have a very big prostate, you can safely go at 12 o'clock and let it fall on both the sides. Here he is doing at 11 and 1. He has left the mucosal strip as you do in a small prostate. So
Okay.
that is what I was asking him, that why he is leaving this tissue between 11 and 1.
It gives some additional support for the apical mucosal tissue, sir. Other than that, usually we might leave at the anterior apical mucosa, which tends to hang down. But if you have a strip there, so it will act as additional supporting for holding it together. And this step has actually demonstrated in some of the studies to give very good continence post procedure.
But no, that's very true. But the question is that if you have very large adenoma,
Large gland, it might not be feasible. Yes, if there is significant tissue anteriorly,
So
then
if
we
you
might not be
happen
able to do.
leave this tissue, it all falls and then it blocks the fossa.
Blocks the view. True, sir. Very true, sir.
So large glands leaving lot of this thing anteriorly, it may not be feasible or should not be done.
But with that strip, do you achieve a early mucosal release?
Yes, sir. We might have the incisions here. It will not be a complete mucosal release. So here's the bleeder at
just show to
11
the
o'clock.
if you have a vessel, how do you coagulate?
Yeah, we have to come back a bit, contrary to what we do in TURP. So the energy required for coagulation is lesser. So I'm using the same cutting settings, but I've defocused. I've come back a bit. So the energy delivered there is less, and it creates a coagulative effect rather than the cutting effect. The same setting, I go closer, it splits and creates a cutting effect. But if I come back a bit, it gives a coagulative effect. So if this kind of a thing is there, the bleeder will keep bleeding unless it is detached. So we have to separate it from the adenoma side, and then the coagulative effect comes better. So unless it is stretched, it tends to keep bleeding. So I think I'm slightly deeper here. That is why though I'm finding the vessel capsule fibers, the bleeders are more prominent. So I might change it and move a fraction towards the adenoma. So we have the option of firing in the middle between the capsule and the adenoma, or firing towards the gland, or firing towards the capsule. So we can course correct, like sir told, depending upon what findings we are getting. So I can change here a bit, since I'm maybe probably slightly deeper, and instead of firing here, I can fire towards the adenoma. But even if there is a perforation in HOLEP, it is usually an incision, unlike in TURP where we lose a chunk of the tissue. So perforation here is actually an incision in the prostate capsule which has happened. So anytime we can course correct it, we will have a flap. So very unlikely that we will have a large defect in the capsule, even if there is a perforation happening.
No, you are doing well. You are in the right plane. This vessel's blanching effect is seen, and coagulation is concurrent coagulation is going on. So I think plane is nicely seen. Don't worry.
Okay. So I come back, dissect it more distally. So the dissection of the right lobe has happened from around roof till around 9 o'clock.
Yeah, I think that's very important that you maintain the anatomical orientation correct. What happens if you lose the plane?
Uh, in HOLEP, the Holmium laser is a tough taskmaster. If you go into the adenoma, the procedure becomes more and more difficult. The gland, if you can't cut through the gland so easily with Holmium, unlike in the thulium, so wherein you can go through the adenoma and join the grooves, you have to come back, identify the correct plane again, and correct your course. So there is no shortcut here in adenoma. But yes, once you are in the correct plane, it gives you very beautiful dissection.
So I think that is the bottom line, that maintain the correct plane is the very, very crucial. And you are demonstrating that how you maintain the correct plane. And that plane was visible very nicely at this thing, right side. Yeah, here. This is the plane. Good. You can continue. And so the lesson is that if you sight a plane correctly, you maintain the plane and work. What you should notice is that he is advancing and 1 centimeter, coming back, again going to 1 centimeter. So come back to the correct area and then go further like this and come back like this. So these movements are crucial. They are described as sweeping motion. So you have identified the correct plane and you are doing this sweeping motion and advancing gradually. So this kind of a movement is the one which enucleates, it replicates finger enucleation. So when we
Yes.
used to do open surgery, it is something like that. So instead of going into the adenoma, you better maintain the plane. So that is for the beginners who are learning the HOLEP enucleation. See, he's coming back to the same site.
Always from a known area to the unknown area, widening the landmarks.
You call it a defined area to an undefined area.
The undefined areas.
So if you maintain that defined area to an undefined area, then you are less likely to lose the plane. And even if you lose the plane, come back to the area where you had the correct plane. So that will orient you once again.
Are you using any mechanical force?
At this zone, mid zone, some amount of gentle traction also will open up. So it will look as if we are pushing a lot of mechanical energy and mechanical enucleation.
That's what it looked like just now.
Yes, but that is the happiest part of doing enucleation with any energy source, because that is the only part where it looks very beautiful. But other than that, there is not much of a mechanical energy that we need with HOLEP. That is the best part. The dissection happens with the cavitation bubble which creates, and you enjoy actually what gentle effect it creates rather than using energy, mechanical energy rather. So the only thing that you need is a gentle traction on the adenoma, only adequate to make the fibers taut. It is sort of a dissection and not rather than a creating of the plane. It is something like a sharp dissection with the scissors. So we will not be able to cut through unless there is a traction and a counter traction. So that is the only kind of energy that we'll be needing with Holmium enucleations. So we are almost through with releasing the apical area.
What about bladder neck area? Because that is one of the very critical area again, because you may do some trigonization and all that.
Yes, if we are doing a trilobar or a bilobar thing, bladder neck is relatively easy because we have created 2-3 landmarks for ourselves to identify and orient ourselves. Vis-a-vis, if we are doing a en bloc, their bladder neck dissection is actually more trickier. So whatever time we gain in en bloc enucleation while not creating additional grooves would be taken for the additional safety that we need at the bladder neck. But yes, again, identifying the principle remains the same. Identifying the landmarks and respecting them and playing it safe is better. So, but the minute here, the crux again will be being in the correct plane. If we are deeper, then we might undermine the bladder neck. So I've joined the groove at the base and the floor, and the right lobe is getting lifted off now.
Yeah,
I'm
you are
just connecting the two
attached
grooves.
at 9 o'clock, nearly 9 or 10 for this thing. 8, 9 o'clock, yeah. I think what Dr. Deepak Kripekar asked, the amount of pressure, very, very balanced this
It is
thing.
only, only to see what is there behind,
Yeah.
rather than create a cutting or splitting effect.
If you see the resectoscope is working, as in open surgery, you need a retractor. Here you don't have a assistant to retract. So it is the resectoscope which works as a retractor and shows you the plane. And once you sight the plane, then you are able to give holmium energy to that angle, at that particular angle. So it's the pressure or mechanical pressure is used only to show you the correct plane. And then you dissect with the energy. What happens if you put only mechanical force? You don't use energy, then it bleeds. So what is the difference is that what bleeding is becomes less if you are not using totally mechanical.
Yeah, Dr. Bapat years ago started doing enucleation in Pune, but he
Yes.
was using more of a mechanical force
So it
and
used
he
to
would
bleed.
use laser only to coagulate.
Yeah. So
Which-
that I have seen Dr. Bapat doing these holmium enucleations in the beginning. And what my observation was, it used to bleed slightly more.
Because
And
he was using a more of a mechanical force than energy.
yes. Here, if you see, it's all whatever is bleeding is being coagulated concurrently. So if you see the bleeder and another point which I must say is that don't waste your time on bleeders towards the adenoma. Sight the capsule, bleeding source from the capsule has to be coagulated rather than spending any time on, because some bleeders, the other side also may trouble you, but leave it alone. Very nicely going on, Taif.
Very, very nice.
Yeah.
So this
Have
is
you
the
reached
zone
the
where
bladder neck area? No.
no, sir, not yet. I've opened reached the bladder neck at this part.
This is the bladder neck.
Bladder
Yeah.
neck. Okay, so I can release it further here and join it, find it out. So if I use a lot of mechanical energy, I will not have control as to where these fibers will split, whether they will split at here, at this point, or at this point. So the control is much less on that.
That is the problem with thulium fiber laser. Thulium fiber laser doesn't show you the dissection in this plane. It can cut anywhere.
True.
That is why they call it a less learning curve in thulium fiber, because you can cut through the adenoma also. But here it is dissecting. Pulsed nature of this fiber laser is sort of giving you that pulsed energy and showing you the plane. Is that correct, Taif?
Yes, sir. Yes, sir.
So that is why you are able to see, and this is that vessel which gets coagulated by defocused beam.
Defocus. So these are the bladder neck fibers. I'm trying to be more superficial here. Not this is the capsule. So until I am on the safer side, leaving few fibers of the bladder neck, nothing to worry about the undermining. So I'm slowly sweeping the adenoma towards the base, towards the floor rather. So the minute I feel I'm slightly deeper, I can course correct and leave a fraction of a millimeter extra fibers here. So because we will be cutting one fiber at a time, the precision is there. So this is the only advantage I feel compared to doing this procedure with a TURP loop, where we will not be having this amount of a precision of every fiber, and course correction might be slightly crude.
Yeah, the pencil tip nature of this fiber
Nature of
is
the fiber, yes.
something which gives you precision, much more precise. You can.
So I will now come back and continue the dissection and try to join it.
Yeah, so this is step sometimes in very large glands where you have scaphoid fossa and it dips deep down into the mid fossa. This step may be very, very difficult. So you have to balance out between the anatomical predisposition of the prostate has to be seen in the beginning. Here it is easily coming out, but sometimes you are stuck posteriorly. And so therefore the message is that posterior dissection and anterior dissection may be combined one after the other, because laterally you don't have any risk. The risk is all either posteriorly, majority risk is posterior. Undermining, going outside the capsule, perforation towards the rectum, they all happen posteriorly.
The slightly other end at this area, the plane is not as smooth as we found in the slightly previous zones. So we have to be gentle, identify that. You can see here the adenoma is slightly other end and not getting lifted off as smoothly as it did slightly.
So what do you do if the adenoma is badly adherent?
So we can take some time, identify, include it with the lobe itself, or if it is stuck and at a very crucial junction, you can leave it across, go slightly above, come back again and tackle the only lobule later on.
Yeah, I think the message is that you come from the other side. It may be adherent at a particular point, leave that point, come from other two sides, and then narrow down that area which is badly adherent. And then you are able to reach and dissect it properly. So you can see that here the dissection is very nice towards the neck, and adherent area was in mid fossa, which can be tackled now. What is your view on widening the bladder neck in the beginning itself? Taif?
Yes, sir.
This bladder neck, if you widen it in the beginning itself,
yes, sir,
that helps you a lot.
Yes, sir. Yes, true. I think I stopped short in widening the groove here. Like you said rightly, the more if I had widened here, the landmark would have increased and part of the dissection, this part would have been done initially itself.
Now, this is the mechanical force which is being used. So at times you can combine the pressures, but this is all very judiciously to be done. Goal is to open up the plane.
As compared to a TUR, how much is the fluid absorption in HOLEP?
It depends upon what we create, sir. Otherwise, if there are no sinuses which has opened, so the other factors remain the same.
Because in TUR, you reach capsule at the end of the procedure and still you have water absorption.
Yeah, if you are doing a large gland, and if you are using a Nesbitt technique, until if we have everything is going on well, the absorption would be the same as this thing. Otherwise, if we end up doing a capsular perforation, then it is almost the same. So we have not found any additional risk as such.
Because you are on the capsule right throughout.
Yes, sir.
You are at the capsule right throughout.
The advantage of enucleation is its disadvantage as well, sir. Any complication
very
upfront?
interesting publication by Hemendra Shah on complications of HOLEP, where he has mentioned an average 80 to 80 gram plus glands, the average absorption of saline was 246 cc. That is what he has published. So there is absorption, and that has value, especially in cardiac patients. If you have a patient who cannot have that, so one has to tailor the technique when you have very poor cardiac reserves.
Okay.
Suppose you are having a patient with 15% ejection fraction or cardiomyopathy, then obviously one has to be very more careful that you don't have any sinus open.
You can give a diuretic,
Yes, we have to
doing
give.
the procedure,
This is the stage
blood
when
pressure is
you.
normal, then you can give 5 or 10 milligram of Lasix actually,
Yes, that's true. We must ask our
That has
anesthetic.
been our practice in the past. If we are doing large gland, we tell the anesthetist to keep an eye on all the parameters and check.
And another thing is the blood pressure, because the pre-operative blood pressure stabilization and control is very crucial. Because if these patients, if you have high blood pressure on table, there is going to be problem.
This is the 7 o'clock feeder vessel at the bladder. No?
Yeah.
Yeah.
But the beauty is that when the bleeder vessels do come, but then because the laser has the coagulating ability, they get coagulated simultaneously.
Yes, sir.
So that is beautiful. The only problem would be if you have really cut through the vein. What will you do? Suppose you are doing a good dissection and a vein opens up or a sinus opens up.
It will be very difficult to control it. I think we'll have to leave it, come from the other side, and until that time, the adenoma would be pressing it, and a compressive effect to some extent saves it.
Yeah, I think that's a learning for the youngsters, that the compression of the adenoma prevents any mishaps. So leave it, if you open a sinus, leave it for that moment and compress with the adenoma and come from the other side.
As far as TUR is concerned, if a mishap happens, you are in a position to call it a day and come back another day and do the job.
Yes, sir.
What would happen if something happens like this, where you have half resected the prostate, half enucleated the prostate, and you need to stop? What will you do?
So this is like an all or none situation, sir. Unless one lobe has gone, there would not be any advantage for the patient. So very difficult that in such a scenario, only the hemostasis and leaving whatever stage we are and coming out would be the thing, and come back for a later date. So unless an adenoma, at least one lobe, either the median or one lobe is completely enucleated, unlikely that the patient might have any benefit. Unless over a period of time, because of that dissection, there is some avascular changes that happens, and there's a shrinkage of the gland. But we wouldn't be expecting any improvement.
But you
So
can
that is the
always
advantage of, say, a Barnes technique, where we have control, and whatever time we exit from the procedure, we still have achieved some amount of advantage for the patient.
So it is possible to put a catheter and come out and go another day. That's possible.
Yes, sir.
No, that is possible, sir. But question is that it is feasible to complete the procedure in HOLEP. The reason being that it is not that disastrous, as somebody has put now, that studies have shown that HOLEP absorption is 100 to 150 ml per hour compared to TURP, which is 600 to 800 ml per hour. So that is one advantage. The second thing which I would like to know, what is your anticoagulant policy, TUIP, for HOLEP?
If it is safe enough to discontinue, we discontinue. If not, we will convert to a bridge therapy on low molecular weight to heparin and continue. It is feasible to do, but yes, if it is an anticoagulant, intraoperatively we might have difficulty. If it is an antiplatelet, probably post-operative also there might be some oozing. It is feasible, slightly higher chance of amount of bleeding and rebleeding rates.
The patient who has had, say, 1 week back this angioplasty with dual antiplatelets.
Yes, sir.
What is
So we
your
can't
suggestion?
stop there. Yeah, we can't stop there. If he's fit from the anesthesia point of view, we can proceed ahead. But with so many new options coming up with Rezum and all, this discussion takes a different turn now. So we have the option to
in
tackle the
your
gland with the
opinion-
much.
Anil, let me just interrupt here. If
Sir.
you say that somebody has got a PTCA done 1 week back, I think so there is no emergency to rush.
Yes,
Prostate surgery is a planned operation. It is not an emergency operation. You can leave a caster, ask the patient to wait till his cardiac condition is stabilized. Then only you can go ahead and do the procedure. What is the urgency to rush?
Urgency is, sir, these patients sometimes large prostates have recurrent clot retentions.
Yeah,
So-
that is an emergency situation.
Yes, yes.
Then you have
So-
to intervene.
So we have had similar cases, and that's why we had one of the patients we had done the arterial embolization, and even after artery embolization, he was having recurrent clot retention. So one had to proceed with guarded prognosis, but we could achieve good result. So this is all spectrum of cases, complex
Yeah,
cases.
see, exceptional cases has got no meaning, but what we are
Yeah.
talking here is in general way. If somebody has emergency, life-threatening hematuria or something, then you have to intervene.
Yeah.
But you have to explain the risk to the patient and family. If he dies on the table and something, then blame will go to you only, nobody else.
That's true. Now, what is your policy type on patients where you cannot stop anticoagulants on while valve replacement patients?
We can go ahead, sir. Like told, if in the cases where we cannot discontinue, we can definitely go ahead while on anticoagulants. We can convert it to a bridge therapy and continue. That way, we will have a control over the anticoagulants also and proceed with the surgery also. We might have slightly higher chance of intraoperative bleeding, but definitely it can be done safely.
Yeah, I think what Taif is saying is absolutely correct. I get such patients from Dubai and other international places, and they especially come for because you cannot stop the acetrom or other things which they are taking. The only precaution we take in these cases is that they have been told that INR should be 2.5, 3, they have to maintain. But when we consult with our cardiologist, he says that, sir, we can give you INR of 1.5 to 2, kindly proceed. So that point has to be taken into consideration, and this is a feasible surgery. Because sometimes such prostates, they will have recurrent hematuриas, and you have to deal with them.
Now the right lobe is done. So we'll proceed in a
Beautifully
similar
done,
manner.
Taif. Very good.
Thank you,
Very
sir.
nice.
Very
So
good.
we'll be
Nicely
replicating
done.
the same procedure on the left as well.
Yeah. Here, I think when we were watching TURP, here you can appreciate that apical tissue is gone completely in the beginning itself. So that is scooping out of adenoma in the beginning. So you start with apex. And what about type this antero-posterior dissection technique? Have you used it? The Japanese are very fond of antero-posterior dissection technique.
Okay, coming from above down to prevent the pressure on the tract.
Yeah. And what Dr. Gupta was highlighting, the omega technique,
Yes, sir.
that versus the standard 12 o'clock incision.
Yes, sir.
These multiple techniques have come in literature. The goal is to prevent any stress incontinence and leave any anterior adenoma. And I think we can definitely tell this thing. When I always train my youngsters is that I have dissected one lobe, the other lobe can be given to the youngsters. Because it becomes very, very easy. Because the more space, better irrigation dynamics, and you dissect first, and now you can appreciate that it is coming out so easily because there is space and the adenoma can go to that space.
True.
You are currently at 3 o'clock.
Yes, sir. 2 o'clock and 3 o'clock.
Yeah. So this orientation is very crucial. When anybody wants to learn HOLEP, he should not lose the orientation. You make the prostate fall from above, you make it lift from below, and then the mushroom stays at 3 o'clock or 9 o'clock. So this is 3 o'clock, and now you can appreciate that how the capsular fibers are seen right up to the bladder neck. And that's why it is said that size doesn't matter. As far as enucleation goes, even if it is 200 gram prostate, you can safely enucleate. What is your take on large glands, TUIP?
Sir, yes, sir. Definitely, size is not a upper ceiling limit for enucleation. I was more concerned about the trend of advocating laser enucleation even for smaller glands and
Very true.
underplaying on the role of TURP completely. So I'm not very convinced about that take. So otherwise, upper limit, I don't think so, because there have been reports of 300, 400 cc glands also being handled. So we are
Nowadays,
well beyond that.
robot simple prostatectomy coming up.
Now we have a robotic simple prostatectomy.
Sir.
If somebody has got a 150 gram, 200 gram prostate, why not to do a robotic simple prostatectomy? Instead
So where
of
you place the limit? Where you place the limit?
Just listen 1 minute. No. It's like when we are talking of new technology, so in that direction, we have got a simple prostatectomy. And if you go back to the literature, thousands of cases have been done robotic simple prostatectomy now. All over the world, I am talking, not in India, but in India also we are doing. So my philosophy is now changed a little bit. If somebody has a 150 and 200 gram prostate, why not to do a robotic simple prostatectomy? To avoid, injury.
Definitely feasible options.
Please make comment on that, actually.
So definitely a feasible option, sir.
It's a absolutely feasible option. Only thing is we have to convince the patient, family.
The pros and cons are totally different for each.
Yeah,
that's a invasive procedure, bladder incision, and transperitoneal approach versus a transurethral approach. So the post-op morbidity pattern will be slightly different, but definitely totally safe and feasible and effective option as well.
If Mallikarjun is there, I like to listen his comments.
Yes, sir, we are doing that as well.
For a 200 gram prostate, for a 200 gram prostate, I would definitely prefer a robotic suprapubic, which would save the urethra and so many things, as long as patient can afford it.
Yes, sir. We have started doing robotic simple for all the cases which have got more than 200 grams, sir.
Correct.
That is what I wanted to hear, because you are doing at 200. Some people are doing even at 100. So
that's the thing. See, we have got a very, very clear understanding. We pass the receptoscope up into it. If I am able to come onto the top of the gland very easily, without much of a difficulty, I may think about HOLEP. If it is not reaching easily, then I think about a robotic simple prostate. I give that option, both of them together, much before the patient, and I decide on the table.
No, pre-operative counseling, how do you do?
That's why I said I always decide on the table. If suppose it's already 300-400 grams, then I think I'll go ahead with the robotic prostatectomy.
See, that's why, there are so many things available in prostate. So the more important question has become how to select a procedure for a particular patient. I think so now our days have gone when we have no other choice, but we used to do either open prostatectomy or something like that. But things have now totally changed. So I think so the understanding of the whole disease, the variety of things available, and you have to select out and do the proper counseling of the patient and our aim should be to give best to our patient.
One thing for robotic mastectomy is, I think we think
Your voice is not good. Voice, please check.
Otherwise, the robotic prostatectomy, the incontinence, the stress incontinence part is not at all there, sir. We presume that it is there, but it is most of the time not there at all.
Yes, I agree with you. That is my experience also.
No, in fact, we changed the technique a little when we do.
Your voice is breaking, cracking, Surya. Can you repeat the question? When not audible. One thing I would like the audience to notice the hand movement of Dr. Taif. If you see the hand movement, see the angle at which he is working. This is very important. Some people always ask stress incontinence despite adequate precautions you have taken in dissection. But the 360-degree movement of the resectoscope is what causes a sort of a Lord's procedure for the external sphincter. So I think there is some part of mechanical stretch onto the sphincter when you create this 360-degree movement all around the. So this is something which has to be observed. But all these stress incontinences are transient in nature because you are so careful about apical release, maintaining the sphincter and dissection proximal to sphincter. But then this cannot be avoided in HOLEP because you have to go all around.
Comments, Taldo.
In large glands, we start at least whenever the patient comes in the OPD, we start Kegels exercises in pre-operative workup of these patients.
That we do in our radical prostatectomy patient for cancer prostate. We don't do that kind of counseling in our TURP. I never do that.
Yeah, but for HOLEP in large glands, it is advisable. I showed you the hand movements. So this hand movement is one which stretches.
Hello.
Surya.
Anil Vashne, sir.
Yes. Now we can hear you.
Taif will be operating. So we'll have a talk by Mallikarjun sir on incontinence, urinary incontinence during transurethral surgery. We'll be watching Taif and then we'll listen to Mallikarjun sir.
Perfect.
Okay.
Go ahead.
Okay. I think the PAP part. Okay. Left floor. But my talk is going to be very, very simple. The whole concept I wanted to make the beginners understand is we always presume, we just wanted to talk on that. Physiology of continence. We still have driven with some ideas thinking that there is an internal sphincter which is necessary for passive continence and there is an external sphincter which is necessary for active continence. This is what is driven with majority of years, so many years, and we still believe in the same thing. So what is actually necessary for a passive continence? What is necessary for a minimal stress avoid minimal stress incontinence, and what is necessary to have a significant active continence with a severe stress? I mean to say to have a continence without stress. So clinical questions, if we look at, we have three sort of a clinical questions. If an external urethral sphincter is only thing for active continence, how to explain post-TUR and post-RRP passive continence? People who undergo a RRP, they are still having a passive continence. How do you explain that? Passive continence means leak, no, not leak, continence at rest. So why the resection beyond verumentanum leads to incontinence? That's a thing which we'll answer. And suppose if the if there is a external sphincter that is externally US, what we are talking about is the only thing what is necessary for to preventing stress incontinence. Why patients who underwent transpubic erythroplasty are not having stress incontinence? That means there is a reason why people are not having stress incontinence in spite of absence of the external urethrosphincteric mechanism in the pelvic floor area. So incontinence after TURP, sphincter injury means what? So if you look at sphincter anatomy, I'll go to two types of sphincter. An inner lithosphincter, which extends from the bladder neck down to the pelvic floor or a pelvic diaphragm, and an external sphincter with a lot of concentration in the external part of it or membranous urethra in the towards the pelvic floor. So there are two sphincters which we are talking about. If you look at the inner lithosphincter, it extends with a more concentration in the in the bladder neck area, with a lesser concentration right under the submucosa, right up to the pelvic diaphragm. So it's the main part at the vesical orifice, whereas rhabdosphincter is main part at the membranous area, which we have thought about as membranous, we said internal and external. This is a US apron which is seen a radical prostatectomy specimen. When we are taking out the DVC, after taking out the DVC, you will see external urethral sphincteric rhabdosphincteric apron in front of the circular smooth muscles of the urethra and the longitudinal smooth muscles of the urethra. That is a US apron which is outside. This is not a thing which gets injured in your TURP. The TURP doesn't even reach the sectional urethral rhabdomyosphincter at all. What has left behind is only this smooth muscles which is there around the urethra. So if you look at sphincteric function, it is passive continence, that is continence at rest. Active continence, whenever there is a stress, there is no leak, that is called active continence. And the last one is going to be voluntary interruption. Somebody is passing urine, they stop passing urine. That is called voluntary interruption. So how do these contribute for it? We'll go into it. What prevents incontinence? One, mucosal coaptation was one thing which I started disbelieving because iTIND doesn't have a mucosal coaptation, but still patients are continent. The second is a smooth muscle sphincter, lithosphincter, intact and of a sufficient length. Third thing is a rhabdosphincter, a fast twitch muscles which are there, which I've shown just now around the urethra, which are necessary at the time of acute stress. And the last one is levator ani, that is the pubourethralis muscle, which make a U-shaped, which is necessary for a complete closure whenever you want to voluntarily interrupt. So external urethral sphincter, what you have seen, and the inner smooth muscle, and a pubourethralis muscle, which is a U. So if we look at clinical situation, continent at rest is always, that is passive continence, is always by the lithosphincter, that is a smooth muscle sphincter under the submucosa, which is extending right from the bladder neck down to the pelvic diaphragm. If you take out the prostate, you end up in having only this amount of the length, which is called the actual functional urethral length. This is what I was talking about. If you have a 1.5 centimeters of functional urethral length, patient will have a fantastic continence and there is no stress incontinence. As it decreases, the chance of passive continence may be there, but stress incontinence will be definitely there. If it becomes much more lesser, that becomes completely incontinent. So whenever there is a prostate which is growing beyond the verumentanum, like what I was talking about, maintaining this length of the urethra next to this apex of the prostate under the lithosphincter is of utmost importance. If you resect it here, the functional length decreases and incontinence is going to be there. So that is a functional length which we need to understand. So the active continence is length of the urethra, membranous urethra, or the length of lithosphincter is for passive continence. External urethral sphincter is necessary for preventing some amount of active continence. For voluntary interruption, this red line, that is a pubourethralis muscle, which contracts towards the pubis, which is necessary. So three components which are necessary for a proper continence. So learning what we have is adequate lithosphincter length, whether it is from the bladder neck to the apex of the prostate or apex of the prostate to the pelvic floor. 1.5 centimeters on either direction is enough for having a good continence. That's the reason why even if you have transpubic erythroplasty, if urethra is anastomosed to the anterior part of the pubis, anterior part of the prostatic urethra, patients don't have stress incontinence. So what is necessary for preventing stress incontinence is also smooth muscle, not the external sphincter. So the reinforcement of an active continence, that is severe stress or voluntary interruption, requires rhabdosphincter and the levator ani muscle. So stress is not because of external urethral sphincter weakness, not a rhabdomuscle sphincter weakness alone, but because of a loss of the length of the smooth muscle inside the urethra. So that is what is called functional urethral length. So what happens in large glands? The whole functional urethral length is shortened. So even losing 2 to 3 millimeters here is going to be detrimental for the patient. So maintaining that amount of tissue next to the on either side is of utmost importance. That's the reason why people do have a little amount of stress incontinence after enucleation, become all right over a period of time once the remodeling of the sphincteric area appears. So in a large gland, what we are talking about is this is the area, verumentanum, and the thing which is gone beyond the verumentanum. So retaining that amount of length, what we have discussed during our TURP, is essential to create that functional urethral length. And then incontinence in prostatic surgery is most of the time is a short functional urethral length and surgical trauma to the sphincteric muscular structures. The surgical trauma happens when you do a retropubic prostatectomy or a radical prostatectomy, and the loss of functional urethral length can happen in TURP also. So what causes incontinence in TUR? Listo and rhabdosphincter. Rhabdosphincter injury is very unlikely. It is always listosphincter because of thermal or a resection injury. Tear during acute angulation because of penile ligament, which is very tight. Mechanical stretch during enucleation all cause some amount of damage to the listosphincter, therein causing some amount of incontinence. Bladder dysfunction and overactivity is the last thing not to be forgotten. So lots of listosphincter. If you see this video, you see this is already an entry, and if you see verumentanum somewhere there, and we resected all the lobe on either side right up to the pelvic floor. So the length of the urethra, what is there as a listosphincter, what is left behind from this pelvic floor to the existing area is only few millimeters. So this patient is going to have significant stress incontinence or sometimes maybe incontinence itself. So lots of listosphincter. So this area, if you resect too much, you end up in having shorter urethra leading to incontinence, that area. So anterior commissure tear, whenever there is a tight anterior commissure or when there is a bending of the penis which happens, see this anterior commissure completely torn. But most of the time they cause stress incontinence, they heal and become all right over a period of time. So if you look at types of incontinence, either total because of very short urethral length, functional urethral length, exertional incontinence because there is a compromise in the length, or there is a external sphincteric injury, and the last one is dead sir overactivity. Well, that is not a point here. How to prevent incontinence? Mucosal incision at the apex so that adequate length of the listosphincter is set intact. We have discussed about that point of scooping the tissue underneath that smooth muscle so that the length of the smooth muscle is going to be retained. And the third thing is going to be avoid thermal injury around that sphincteric area. Those smaller bleeders are there, don't need to worry about it. Relatively more proximal at the roof compared to the floor. Perineal ureterotomy when acute angulation is disturbing. Mucosal incision, this is what we are talking about, wherein we see the mucosal incisions being given beforehand so that we retain that amount of length of the mucosa so that we will not be damaging that amount of smooth muscle. So make a mark and then start. Yes, that is a marking which you preemptively do and see that you retain that amount of the mucosa beyond which resection should not happen.
Okay.
And resection preserving listosphincter is this is what we demonstrated. Instead of losing that length, you scoop the tissue from the smooth muscle and retain the smooth muscle. So these flaps which are there, please retain that flaps. Don't exercise that flap thinking that they are obstructing. No, we need to scoop this thing by retaining that flaps, and that flaps are going to be utmost importance. We just demonstrated in our previous surgery. Perineal ureterotomy. Sometimes we have a patient where we will not be able to reach the bladder, in which case that is a very big prostate. We cannot reach the top of it. Either you think about a robotic cystoprostatectomy, or what you do is a perineal ureterotomy, which can be, I want to fast forward it. You give a small incision into the perineum, and then, no, you've gone out. Okay. perineum and make a scope pass into the bladder. We are not able to reach the upper part of the prostate itself. So that's a verumontanum. So still you want to do a resection called perineal urethrotomy. Make a small incision in the bulb, pass a resectoscope, and then pass it through the perineum. You don't need to close that urethrotomy at all. You don't. Most of the time you don't need. That's a bulb. That's the bulbar area. Keep it dilated there. Just let me show the picture. See that it's solid. That's a urethrotomy. And through that urethrotomy, you pass a resectoscope into the bladder and complete the procedure. That's how. And then you just pass a urethral catheter through the urethra and finish the procedure. You don't need to stitch this also. In the cases with acute angulation, this is a very nice approach to do a resection in these patients. That's a corporal tissue. I'm just entering into that area, and that's a bulb which is entered, and then urethra, yes, and then into the bladder, and you will be able to reach the upper part without any problem. This is a perineal urothrotomy described long ago. And then a scopia of a SUI, I think you would all have seen. You'll see that lack of smooth muscle covering at that point, and the length of that's a urethra, and there's a scarring on the area of around that smooth muscle area which need to be preserved. That is a scopy in a SUI. Total incontinence is a classical picture. Everything resected. You don't see anything closing down. Even the veru is not identified. This is a classic case of a total incontinence post-TURP. That's a total incontinence. So sphincter rehabilitation mostly involves only the skeletal muscles. That is a tuborectalis, sphincter, rhabdosphincter here, and a bulbospongiosis. So loss of lissosphincter cannot be compensated completely by these exercises. So strategies to compensate for any loss of smooth muscle or a striated muscle after prostatectomy will not be helpful unless otherwise you have a fair amount of length of the functional urethral length. So maintain, if it's a little compromise, these exercises are going to help. So take home message, SUI and TUR, enucleation of the large prostates, it is common. And multiple components are the reason. Maintaining mucosal integrity for coaptation, functional urethral length of at least 1.5 centimeters, and bladder dysfunction might be as a cause occasionally. Thank you.
Thank you, Malik. Very clear understanding. Did you understand this better after doing robotic radical prostatectomy?
Yeah, absolutely, sir. Our sphincter anatomy, which we presumed what it was, we understood much better. After we started doing a robotic radical prostatectomy.
And then you understood the entire situation.
Yes,
very
sir.
good, very well explained.
Thank you, sir. Thank you, sir. I think the morcellation is happening. Taif, you can give a last comments.
Yeah, Taif,
Yes, sir.
precautions for safe morcellation.
Sir, the most important thing is to have a clear vision. The hemostasis has to be good. That is the first thing, clear vision. The bladder has to be full. The inflow has to be from a dual source. It can be by the help of two bags connected simultaneously or using a third bag from the outflow as well. So adequate inflow to match the suction so that the bladder is always full. You can confirm the bladder fullness either with suprapubic palpation or ultrasound or just the vision here endoscopically. And third, position of the lobe and the blade always in view, and there should not be mucosa towards anywhere in the vicinity of the blade. Eventually, morcellation.
Yeah.
And you should do morcellation close to the bladder neck, not in the bladder.
Yes, sir, not into the thing. In fact, once the adenoma reduces in size a bit, I often tend to get it back into the fossa and do the morcellation in the fossa. Yeah. So that gives some additional safety as well.
What are your tips to cheese ball formations?
Once that ends down, we have to reduce the rotations to some extent, roughen up the cheese ball initially or once we face that. So, but sometimes we might have a tough time negating those cheese balls.
Sir, can you show the prostatic cavity once? Yeah, nice, very nice.
Excellent.
Wide cavity.
Very nice.
Very good demonstration.
Excellent job.
Very good,
Congratulations.
Taif.
Yeah.
I think
Taif,
we should
you
all.
can continue with the morcellation.
Sure.
We'll close the session.
Sure, sir. Thank you
Yeah.
so much for this opportunity, sir. Thank you.
Thank you, Taif. Now, yeah, one second. I won't.
Side camera.
Camera.
Camera again. Sir, छोड़ दी बैठ.
We'll keep this on the.
Yeah, we can.
There are a few comments in this chat box. Surya.
Sir, yeah.
One is the place of green light laser today for anticoagulated patients.
You can take that question, sir.
Oh, no, it's definitely a good option. Green light laser is much more hemostatic, and nowadays it has gone out because of cost reasons. But definitely we had done green light laser when it was available for such patients. And thulium fiber laser has come. This is in principle a diode laser, and where it's had more hemostatic compared to holmium. So we have used both these modalities for anticoagulated patients where it cannot be withdrawn.
I'd like to add one thing more, that there are two different procedures. One is the vaporization of the prostate, and other is the resection or enucleation of the prostate. So vaporization always gives a poor result. There is no doubt about that. And you can do vaporization by green light laser or button electrode, or in our time even we have used roller valve and all those kind of things I have seen. So what I'm saying is, I think so role of vaporization is very limited. With this minimally invasive treatment is available, I think so the role of all this vaporization procedure will be out in future.
Yeah, that's true. Another question is role of relugolix in large prostates. Any comment, sir?
No scientific evidence, but I think many people use it. Many people use bicalutamide also to decrease the vascularity. Well, it's a thought. It's a nice thought, but I think possibly it's not scientific evidence per se.
No, I have operated on large prostates who came from outside already. They had got leupride injections. And they came first to me when it was 350. The next 3 months, after 3 months, they came and the size became 250. So much more manageable. In those days, when robot simple prostatectomy was not available. So I think there is a definite place, but no off label.
There's no scientific proof about it, but it definitely reduces the vascularity and makes the procedures simpler.
Okay. Thank you, sir. Thank you very much.
Not routinely advised, actually,
Yeah.
Normally, we don't prescribe that you should go for this LHRH antagonist first, and then you come back for TURP. Normally, we don't advise like that. It should not be mistaken. Exceptional situation, yes. Patient has cardiac event or something who has to wait for surgery or some other problem, then you can use.
Malik, if somebody has had either bicalutamide or a drug like this, and he comes for a radical suprapubic open suprapubic prostatectomy, do you find there would be a difference in dissection?
Sir, and a long-standing bicalutamide.
I'm asking you this because I had a patient who was on bicalutamide for a long time and then came up for a open prostatectomy, and I did millions, and the planes were not as clean as they should be.
Sir, planes you are lost, sir. Basically, you see what happens why the plane happens between the two adenoma and the capsule, because the growth rate of the periphery and the growth rate of the center is going to be different. The moment you get the growth rate to equal C, what will happen? The planes get fused.
Correct.
So that's exactly, you see, longer the use of any anti-androgens, the planes get fused. So it's not advisable to use it for longer. You want to get a plane, do it in the fresh case, either both in a radical prostatectomy or even in a TURP also, either of the two. I would always say that, because the growth is going to be stalled, the plane is going to be grown.
So Malik, one question that you have had now more than 2 years experience of MIST. What is the long-term outcome in your subset of patients?
Rezum.
MIST means this iTIND UROLIFT,
Sir,
Rezum.
majority of the times my first year gone with some sort of ups and downs because of a poor selection of cases. So the first year, the number of cases done were very high because we right, left, and center, we started advising him. Now we are very, very careful and very selective. So in a selected group of patients, you will definitely get a good results. We see new complications because of our own misunderstanding, but there is a reason for that. But basically, my feeling is in a selected patients, they do wonders, sir. No doubt about it.
Small glands, in India, we have more of chronic prostatitis and fibrous glands. What is your take on such patients? And which procedure would you advocate?
iTIND, sir. iTIND.
Small prostates.
Yes.
iTIND or you can do TUIP, one of the two.
Either of the two. Either of the two.
Depend upon the affordability by the patient also.
Yes, sir. Yes, sir.
Yes, yes.
And you showed beautifully this modified incision of prostate, extended resection. Your take on TUIP versus extended modified resection of this floor?
No. You see, sir, what Dr. Gupta also pointed out, majority of our elderly age patients who require a very small prostate, who requiring a transurethral surgery, we give 2 incisions, one at 4 o'clock, another at 8 o'clock, and in between tissue is resected and rest of the thing is left alone so that the bladder neck contracture can be prevented. But younger patients like 25s, 35s with a significant functional outlet obstruction, we are preferring iTIND. So this is a balance between the two, sir. That's all. The TUR techniques matter depends upon the size of the gland, etc., etc.
We'll complete it, sir. All the questions.
I think most of the questions are done. You must be having, if there is anything left, we can
type it later.
There is one question that how often your patients who have undergone Rezum or UROLIFT will require TURP in future. I think that you have answered partly.
I think, sir, it is a known fact that possibly 10 to 20% may require a resurgical intervention, some sort of an intervention. But what we are not clear is at what time. Is it because of the primary failure or a failure happening after 5 years? We are not clear about that. We are going to be prepared for that sort of a mindset in future.
With the proper case selection, that figure may come
Yes,
out.
with the proper counseling and case selection, both.
And there is another question. Out of the 3 missed procedures, which one is more rewarding in your experience?
Rewarding depends upon, that's what exactly
Patient
what
selection.
Patient selection. That's it.
It has come
That's a supreme.
Yeah, I think
that is a
very
supreme.
delicate balance is there.
That's a very, very supreme, sir. We err on it to promote mist. Don't err on promoting mist.
Very true. I think
That's
that is
exactly.
the bottom
That's
line.
the point. That's the point.
See, I will like to put it in another way that it is the expectation of the patient. So when they came for robotic radical prostatectomy, everybody was thinking that we are going to have an excellent result for by way of continence and these things, Similar applies to these minimal invasive treatment. So you should see the expectation of the patient also, what he wants. And so counseling has got a more important role for satisfaction of the patient. Otherwise, he will think, I have spent 3 lakhs, 4 lakhs rupees, and still I'm not getting the good result. What kind of treatment you have done? So you will lose your patient, you will lose your name, and ultimately that procedure will be in disrepute.
You are absolutely right, sir, because my take on this is let the patient demand this particular surgery, because as the patients are now fully aware and they read and then we tell them the pros and cons.
Both the clinical condition and patient demand the particular surgery.
Both have to be balanced out. Yeah.
Thank you, sir. I think after seeing all the procedures, I think we have to decide which procedure suits which patient. That's it.
Yeah. So we have added responsibility on our heads.
Exactly. So with this, we come to the end of this wonderful operative workshop, sir. Sir, I thank all the 3 moderators, Dr. N.P. Gupta, sir, Dr. Anil Varshne, sir, and Dr. Deepak Kirpekar, sir, for your valuable insights. With all your great experience, you've been here since morning, watching and giving your valuable suggestions. Thank you so much, sir, for being there. And now on behalf of USI and ISU, I sincerely, my heartfelt thanks to Mallikarjun sir and his team, all the team who have been working very hard and they've been preparing for many days, last few weeks, I can say. Yesterday also, sir was very kind to do a trial workshop, transmission. And if we all know, sir, Mallikarjun sir is a great teacher. He has got passion for teaching, and he has been teacher for many of us, directly or indirectly. I can say that I have learned so many things watching his videos. Thank you so much, sir.
It's my pleasure. Thank you. In fact, you gave me the opportunity for me to operate in front of the greats of prostate surgery in India. Gupta sir, Deepak bhai, and Anil. Thank you so much for giving me this opportunity. I'm sorry for some small hiccups. We occasionally face this in Hyderabad because of these cables being cut on the roads because there's temporary Wi-Fi shutdowns which happens occasionally. Sorry for that today, though we tried it yesterday. Thank you very much for this opportunity.
But anyway, it has
Thank you.
gone very well. And Malik, I must thank, and I thank this USI ISU for making this workshop wonderful. Thank you all.
Thank you, and I thank my
Thank
anesthesia.
you, everyone.
I'd like to read the last comment here also. Excellent demonstration. Thank you very much.
Thank you,
Excellent.
sir.
Thank you.
Sir,
Thank
we
you,
thank
Malik.
all the anesthesia team and nursing team, all the technical staff of ANU who have worked very hard to make this workshop successful.
Thank you, sir.
Thank you. Thank you very much, sir.
From
Thanks
Sri
all
Lanka,
the audience for watching.
Dr. Surya, we have received comments from Sri Lanka also. And
Yes.
The comment is that thank you very much for the enthusiastic faculty and the technical committee. So that is what from Sri Lanka. Thank you very much.
Thank you, sir. Thanks for this. Thank you.
Thank you. Bye-bye.
Thank you so much. Yes, sir. Thank you, sir. Amazing, sir. You're very Moral of the whole story is जो दिख रहा है उसी को करो, जो नहीं दिख रहा है मत करो. I think excellent workshop. All this is recorded.